Hello.
না ওখানে স্পিকার তো স্পিকারের সামনে তো মাইক্রোফোন ইউজ করতে হবে।
হ্যাঁ তা তো অবশ্যই ইয়ে করবে, নয়েজ করবে।
তাহলে এখন কি করবে?
ওই
অবশ্য
তো
ওখানে কথা
পিছনে
বলা তো খুব
পিছনে
বেশি না।
না না ভাইয়া, ওইটা ওইটা
ওই
সরে
টেবিলে
ধরে
বসে
সরে
কথা
বসতে
বলতে
হবে।
পারবে না?
একটু দূরে বসতে হবে ওইখানে যে।
Hello. Hello.
ঠিক আছে?
1, 2, 3. Hello.
এইভাবে না, ভুল করছে। ঠিকই আছে। ওটাই তো ঠিক। এই দেখো। রশিদ আগে, হ্যাঁ রশিদ আগে, তারপর নাজমুল ইসলাম, ঠিক আছে? এভাবে দুটো দুটো করে দাও। তারপরে ওগুলা ঠিক আছে। এটা নজরুল, মানে নজরুল, নজরুল চার।
within a few minutes, we will start our session. So I will request our respected guests to have their seats.
Hello, 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 check.
Hello. Hello. Ladies and gentlemen, welcome to Bangladesh Cancer Congress 2015. May I have your attention, please? Whoever is staying outside collecting the badge, please come inside. We are going to start the inaugural session now. Ladies and gentlemen, may I have your attention, please? Participants outside the ballroom are requested to come in because we are going to start the inaugural session now. Bismillahir Rahmanir Rahim. On behalf of Oncology Club, we want to welcome you all to the inaugural ceremony of Bangladesh Cancer Congress 2015. You all know that Oncology Club have been organizing this gathering since long 2001. Today we are honored to have our national professor, Brigadier Retired A. Malik sir, who is the president of National Heart Foundation of Bangladesh, as our chief guest. This session will be chaired by the president of Oncology Club and the Congress chairman, Professor M.A. Hai. May I request the chairman of Congress to bring the chief guest and come to the dais. I would also request Professor Hafizur Rahman Ansari, the Vice President of Oncology Club, to come to the dais. I would like to request Professor A.M.M. Shariful Alam, Secretary General of Oncology Club and Member Secretary of the Organizing Committee, BCC 2015, to come to the dais. Finally, I would like to request Professor Ahmed Said, Treasurer, Oncology Club, to come to the dais. Ladies and gentlemen, we want to start the program with recitation from Holy Quran. I want to request Dr. Muhammad Mofizur Rahman, Associate Professor of Radiation Oncology, National Institute of Cancer Research and Hospital, to recite from Holy Quran. Dr. Mofizur Rahman.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الرحمن علم القرآن خلق الإنسان علمه البيان الشمس والقمر بحسبان والنجم والشجر يسجدان والسماء رفعها ووضع الميزان ألا تطغوا في الميزان صدق الله العلي العظيم. In the name of Allah, the most beneficent, the most merciful. Allah, the most beneficent. He taught you, the mankind, the Quran by His mercy. He created man. He taught him eloquent speech. The sun and the moon run on the fixed courses exactly calculated and measured, outstage for each. And the herbs and the trees both prostrate. And the heaven He has raised high. He has set up the balance in order that you may not transgress due balance. Assalamu alaikum wa rahmatullahi wa barakatuhu.
Thank you, Dr. Mafizur Rahman. From the very beginning, Oncology Club was always thriving to uphold the quality of cancer care in Bangladesh. And the founder of Oncology Club, late Professor ABMF Karim, believed that it was only possible by making the change in the quality of caregiver. So his aim was always to improve the quality of the caregiver, which will ultimately improve the quality of the cancer care treatment in Bangladesh. May I request Vice President of Oncology Club, Professor Hafizur Rahman Ansari, to give the address of welcome. Professor Hafizur Rahman Ansari.
Good morning to you all. Mr. Chairman of this session and President of Oncology Club, Bangladesh, Professor Muhammad Abdul Hai, Honorable Chief Guests of the inaugural session, invited guests, and participants of the Bangladesh Cancer Congress 2015. Our Honorable Chief Guest is Brigadier General A. Malik, he is retired, and National Professor. It is an immense pleasure and also great honor for me to welcome you all in this nice morning on behalf of the organizing committee of the Bangladesh Cancer Congress 2015. Cancer is one of the deadly diseases. It's a challenge which warrants intensive research and exchange of current knowledge among nations to deal with it effectively. The aim of this conference in every year in order to get the rapid transfer of knowledge and technologies among participants. In this inaugural session of Bangladesh Cancer Congress 2015, I remember our beloved and respectful founder, President of Oncology Club, Professor Emeritus ABMF Karim, under whose active, relentless work and leadership, SARC Federation of Oncologists established in this region. This year, Oncology Club hosting second annual Cancer Congress. It is my great pleasure and honor to welcome the chief guests of this occasion of inaugural ceremony and scientific conference, and also express my gratitude and welcome to all the learned foreign faculties and participants who have taken all the troubles to travel Bangladesh to make this scientific congress worthy and successful. I am also confident that the participants and the oncologists of Bangladesh will be immensely benefited from their deliberations. I am also express my thankful gratitude to all organizations, especially sponsors, who have contributed a lot and extended their hands to make this scientific conference a success. I am also one to welcome and express thanks to all the media personnel, journalists for covering this program. Lastly, I welcome you all Second Bangladesh Cancer Congress 2015, organized by Oncology Club, Bangladesh, and expect that you will be benefited yourself by active participation and exchanging your experiences with others and enjoy the program. Thank you all again.
Thank you, sir. Emeritus Professor ABMF Karim. He was Emeritus Professor in Netherlands, but he was a son of this soil. So once he realized he should come back, and he came back. He didn't only came back, he established Oncology Club. He didn't only establish Oncology Club, he started action because he was a believer of action. Journey started in 2001. That is, the first conference was organized in 2001 with the proposition of Convention of SARC Federation of Oncology proposal. Thereafter, 2008, then 2012, 2014, 2015, we are here. All through the journey, we had the guidance of this great man whom we lost in 2012, just before our SARC Federation of Oncology conference. But the momentum he created was never stopped. Thereafter, his beloved successor, Professor Hai, took the responsibility. But the person who was always working with Professor Karim and is still working with Professor Hai is the Secretary General of Oncology Club, Professor A.M.M. Shariful Alam. Now I request Professor A.M.M. Shariful Alam, Secretary General of Oncology Club, and also the Member Secretary of the Organizing Committee of BCC 2015 to give his speech. Professor A.M.M. Shariful Alam.
Bismillahirrahmanirrahim. Respected Chairman, Honorable Chief Guest, National Professor Brigadier A. Malik, my respected teachers sitting in front of me, participants of the Congress from home and abroad, my respected colleagues of different specialities, delegates from both print and electronic media, distinguished guests, ladies and gentlemen, good morning to all of you. Oncology Club, Bangladesh is a platform for all fighting cancer. Founded in 1999, the club has been guided by the central goal of improving cancer care and prevention of cancer in our country. Before that, in 1998, concept of Oncology Club was formulated by late Professor M.F. Karim, and it was shared amongst interested persons. Bangladesh Oncology Club is committed to advancing education and training of the oncology professionals, fostering communication and exchange of ideas among cancer-related medical subspecialties, advocating policies that provide access to high-quality cancer care, supporting the clinical trial programs and the need for increased clinical and patient-oriented research. Oncology Club believe that important way to fight cancer is to strengthen regional and international cooperations and collaborations. Therefore, we must continue to strengthen our links with the WHO, IAEA, other healthcare agencies of the world, and with the different cancer organizations of the SAARC countries. Because international cooperation and collaboration is most important for sharing information and experiences. Our circumstances and needs may vary, but we share a common goal of providing optimum and quality cancer treatment to ascertain cure and or palliation of the disease in our country. In the meantime, Oncology Club successfully hosted 1st and 7th SFO International Cancer Conference and 1st Bangladesh Cancer Congress at Dhaka, Bangladesh in the year 2001, 2012 and 2014 respectively. From the 8th SFO International Cancer Conference, Oncology Club had introduced Professor Abul Bashar Muhammad Fazlul Karim Memorial Gold Medal Award to encourage the researchers in the field of oncology of the SAARC countries, which will be awarded to the best research paper of the host country in every SFO International Cancer Conference. Professor Dr. ABMF Karim was one of the leading and pioneer radiation oncologists of the country and was founder chairperson of the Oncology Club. He was well reputed both at home and abroad for his research activities and devoted his life for the well-being and service of the cancer patients and quality cancer care in our country. In the 8th, 9th and 10th SFO International Cancer Conferences held in Nepal, India and Pakistan respectively, first, second and third gold medal of this kind have already been awarded to the best research papers of the said conferences. Bangladesh Cancer Congress 2015 will cover a wide range of topics in the arena of oncology. Plenary sessions, symposia lectures, and free paper sessions by the locally and internationally reputed oncologists are the interesting features of this Congress. We believe that cancer treatment and research are in a new era of rapid and significant development in the SAARC countries and also in Bangladesh. Therefore, it is crucial for young doctors of our country to communicate openly with the foreign speakers, investigators, and researchers through their presentations and vigorous discussions. During the conference, delegates will also have the opportunity to interact with the speakers and to view and discuss posters. Professor Syed Fazlul Haq Memorial Gold Medal Award is another interesting attraction of BCC 2015. Professor Dr. Syed Fazlul Haq was a man of character who devoted his life for the well-being and service of cancer patients. He was one of the pioneer radiation oncologists of our country. From the first Bangladesh Cancer Congress 2014, Oncology Club Bangladesh have introduced Professor Syed Fazlul Haq Memorial Gold Medal Award to encourage young researchers in the field of oncology of our country. The research work must be done in Bangladesh by Bangladeshi scientists. The gold medal will be awarded to the best research paper in every Bangladesh Cancer Congress. In BCC 2015, Oncology Club is going to award second gold medal of this kind. On behalf of the organizing committee, I would like to thank the session chairs and the personnel who have reviewed the high-quality scientific papers presented during this Congress. I would also like to thank participants, especially those from abroad, for joining us and sharing their valuable experience and ideas. Thanks to other members of the Congress Organizing Committee and to the Scientific Committee for their diligent works. My heartfelt thanks to the co-sponsoring and cooperating organizations and different pharmaceuticals industries for their collaboration and support, which have helped us a lot to ensure that this Congress is truly international. I am sure that you will have a stimulating and interesting meeting here in Dhaka. Please use this opportunity to interact with each other to the full in this unique environment and exchange your experience and create ideas for the future. I wish you have a productive and enjoyable Cancer Congress at Dhaka, Bangladesh. Thank you all.
We are going to make a bigger list. Sometimes it looks like a story, how somebody can create something from the ground, from nothing, from zero. How somebody can prove that if you can put one figure in front of many zero, it becomes a very big thing. In Bangladesh, we knew this gentleman as a renowned cardiologist. We knew this gentleman as a pivotal role for the government institute. But when we heard that he is trying to do something in the private sector, most of us who were young, very young at that time, could not believe. But today, if we go to Mirpur, see the huge activities of the institute, then I feel ashamed for that feeling on that day where I thought that it will never be possible. Professor Brigadier A. Malik, our national professor, he is not only a cardiologist, he is not only a national professor, he is that man who made me ashamed. When the first lottery was floated, I thought nothing is going to happen. But when I went to invite him with Professor Hai as a chief guest, I was again feeling that what a fool I was. Bangladesh is proud to give birth to this type of great people who could create something from the ground, something from nothing. That is our national professor, Brigadier A. Malik sir. We are very happy that he accepted our invitation to be our chief guest. Who would be the best person to honor as a chief guest other than him, because he is from our own profession. In our program design, always we have two plenary sessions. The first plenary session in the name of our founder, Professor ABMF Karim. As you know, Professor Malik sir worked a lot for anti-smoking and against tobacco, and he is still fighting against it. In honor and recognition to his fight, we have dedicated our first plenary session on oral tobacco and cancer. Ladies and gentlemen, our chief guest, National Professor Brigadier Retired A. Malik sir, who is the President of National Heart Foundation of Bangladesh. May I request our chief guest to give his speech. Professor Brigadier A. Malik. National Professor Brigadier A. Malik sir.
Bismillahirrahmanirrahim. Honorable Chairperson Professor M.A. Chairman Organizing Committee of Bangladesh Cancer Congress 2015 and President Oncology Club Bangladesh, respected delegates from home and abroad and participants, Assalamu alaikum. Thank you for the tribute, but I think all the attributes belongs to Allah. With a human being, we are just, I think, wasila. So everything should go to Allah. So I thank all of you and the organizer for inviting me in this important seminar on inaugural session of Bangladesh Cancer Congress 2015. Now, as you know, the non-communicable disease is emerging a serious health problem, particularly in our developing countries. All over the world, this is a problem. And this NCD, non-communicable disease, heart, cancer, lung disease, diabetes, they are really a problem. Government alone cannot solve this problem. So various non-governmental organizations will have to come forward, and I congratulate and thanks the Oncology Club of Bangladesh for coming up to fight cancer in the country. The cancer is a disease in many ways. About 1/3 is preventable, and if you can detect in time and early, you can save many lives. The most dangerous things about cancer is, once the disease takes place, the individual becomes crippled, chronic disease, and this is a burden for individual, family, society. And this year, in 2015, the UNO summit, they have decided that sustainable development, if you want to keep it, then you will have to control this non-communicable disease, heart, cancer, lung, and even injury. So you are playing your role, and many other organizations are playing role. So collectively, all of us will have to work together. It is not an easy problem. A problem is not easy to tackle, and it is a chronic thing. For this reason, you know, the common factor is tobacco. In Bangladesh, we have formed United Forum Against Tobacco. Here, the Cancer Society and other organizations related will be happy to learn that recently we have formed in Bangladesh Network for NCD Prevention and Control. And here, Heart Foundation, Bangladesh Diabetic Association, Cancer Society, Cardiac Society, and many 10 organizations have come forward, and this will be come up, and it is coming up. So this will be certainly useful as an emission, and organization like Cancer Society, as I tell you, Lung Foundation has come. So I am sure if all of us work together and relentlessly, that is, this problem cannot be solved by 1 or 2 days. You will have to continue these efforts. So we should give importance on prevention And then obviously treatment is a very important part. After prevention there will be some disease. And for this we will have to have hospitals where the specialists will work, and the facilities at this moment in our country regarding the non-communicable disease, heart, cancer, it is not adequate. I must say that Bangladesh has attained a good standard in treatments, definitely, but this is not enough. So we will have to create more manpower and create facilities outside Dhaka. Dhaka is not the whole, anything he can contribute in various ways. So we should try to do something for good of this community. The Oncology Club, I think it is not the only professional body, so I think professional and non-professionals are there. So they should join hand together for improving the quality of services, prevention facility throughout the country, and we should work hard for this. And my advice to the younger doctors that you should always keep your conscience clear and try to learn and to do good to the patient. Because patient when comes to you, he comes to you with good. He'll always regard you even if the patient is dead. So be clear in your conscience, do good, so there will be always peace in your mind. So I again thank the organizer for inviting me, and I hope this will be very useful, and wish and pray for good success of this meeting. So all of us should try to do good to our fellow beings, and thank you very much for inviting me. Thank you very much.
Thank you, sir. You were our icon. We used to follow you. I think after today's speech, what you said, that will be a message for all of us, especially the juniors, that how we can dream like you, and how, with the support of Almighty Allah, we can also think of creating something big and effective. In this world, many people do many things. And sometimes, many of us cannot recognize what was happened and how it happened. So, who create this, they don't demand recognition, but who enjoy it, they should give the recognition. Unfortunately, the culture of recognition is not very much in our society. But we believe that it is a high time that we to start recognizing the person who has contributed to the society, because this is not for them, but it is for us. Who has done it, they have not done for recognition, but who are enjoying it, it is their sole responsibility to show their respect that we really recognize your contribution. Oncology Club has been trying to recognize people or peoples who have been contributing in this field from the very beginning. We are proud that for the first time in Bangladesh, the founder Radiation College of Bangladesh, Professor S.F. Haq, was recognized by Lifetime Achievement Award in 2014 from this platform. We are also proud to recognize Professor ABMF Karim, who was the first radiation oncologist of the Indo-Pak subcontinent. And his record time, minimum time efforts year achievement is still a record in Royal College which nobody could break. We awarded this great man also with Lifetime Achievement Award in 2014. Professor M.N. Huda, another living legend, who was also one of the few who was honored with the fellowship from the Royal College of Radiation Oncology with FRCR. We could honor him with Lifetime Achievement Award in 2014. By giving this Lifetime Achievement Award in 2014, we could ensure that maybe we have done some of our responsibility. This year, at the chronology, we are trying to continue the recognition. But as you know, Lifetime Achievement Award is not something which can be awarded to any person. Our committee worked hard to identify the next person to award the Lifetime Achievement Award. And we are very happy that today our committee could identify Professor M.A. Hai, Professor M.A. Hai, the Lifetime Achievement Award for 2015. May I request Professor M.A. Hai, as you know, he was born in 1940 in Chapai-Nawabganj, Rajshahi district. He completed his MBBS in 1965 from Dhaka Medical College Hospital. Then he completed DMRT in 1971 from IPGMNR. In 1975, he started his work as assistant professor of radiotherapy. From 1979 to 1986, he worked at Dhaka Medical College Hospital as associate professor of radiotherapy. In 1986, he became the professor of radiotherapy and joined in Sher-e-Bangla Medical College, Borishal. In 1987, he came to join the National Cancer Center as a director, and there he worked till 1993. In 1994, he was moved to Mymensingh Medical College. After his retirement, he didn't stop because a man of action cannot stop. He could go to many other places. First, he went to work as a consultant in Delta Hospital, 1999 to 1999. And from 1999 to 2007, he took another noble task to build the largest NGO cancer facilities in the country, Asane Mission Cancer Hospital. This great man, when thinks the job is done, he moves to new project. So in 2007, he moved to take the responsibility of Khaja Yunus Ali Medical College Hospital, which he say that it is a village. Yes, it is a village, but he created a center, world-class center in that village. In addition, he is also giving the service as an honorary director to the Bangladesh Cancer Society Hospital. This great man, our committee could identify as the Lifetime Achievement Award winner for 2015. In 2012 session, he was elected as the president of SAARC Federation of Oncology. And in 2013, he was selected as the patron for SAARC Federation of Oncology. We have been looking at whom we should identify to hand over the memento. We thought, why not the first fellow of radiotherapy should take this honor? The first fellow of radiotherapy is Professor A.M.M. Shariful Alam. And I request the Director of Cancer Institute, Professor Moraf Hussain, another beloved student of Professor M.A. Hai. These two students of Professor M.A. Hai is a successful successor of Professor M.A. Hai because the chair he left was successfully catered by these two students. Ex-director Professor A.M.M. Shariful Alam and current director Professor Moraf Hussain. I request Professor Moraf Hussain sir to come to the dais, and these two students, would you please take the honor to be with the chief guest to give the crest to our Lifetime Achievement Award, Professor M.A. Hai. Can we all stand up and show honor to this great gentleman, Professor M.A. Hai, the President of Oncology Club and a patron of SFO, and who has been awarded as the Lifetime Achievement Award. Ladies and gentlemen, it is a moment for us to honor this great man. It's a moment of emotion, it's a moment of joy, it's a moment of accomplishment. I think what great thing could happen to somebody to see that his students have successfully taken the responsibility of the assignment that he started. After giving this Lifetime Achievement Award, Oncology Club realized that we should also identify some other great legendary people who have been working as the pioneer in the allied field of oncology. You know, when this country started in 1971, everything was started from the ground. There were great people who created this great thing from this ground. So we recognize the pioneers in their respective field of allied subject in the cancer care management for their outstanding contribution. In this list, we want to remember first, late Professor Dr. Mohammad Abdul Rashid. He is the man who first established the hematology department in IPMR. The department he established is now not only working as a diagnostic hematology department, also working as a clinical hematology department. Thousands of oncological patients of hematological malignancy is getting wonderful treatment, not from IGPGMR, also from all the branches in all the medical colleges. This is the man who started it. Today, he is not among us, but we think that we should remember him, not only remember him, but also honor him. Unfortunately, his family members, his wife is not at home country, so we could not bring them. So I would request one of his beloved student, who is now the head of the department of National Institute of Cancer Research and Hospital, to represent Professor M.A. Rashid. And I would request the first fellow of hematology, Brigadier Zahidur Rahman, who is the consultant of United Hospital, to take the honor to carry the crest for Professor M.A. Rashid and give it to the representative of Professor M.A. Rashid, Professor Mahbub Rahman. Brigadier Zahid, would you please come up? He is the first fellow of hematology in Bangladesh. And I wish today Professor Rashid sir was alive to see that his student, the first student, is now rendering the responsibility. Sorry, correction, Brigadier Zahid Mahmood. There was a time in Bangladesh, the name of the laboratory and histopathology was synonymous. The name of Professor Karim Nazrul Islam and histopathology was synonymous because probably he was the only man who was offering this service. Now, the time has changed. Now we are in 2015. Many histopathologists are working in different corners of the country, but he is the pioneer. Professor Karim Nazrul Islam was born in 1931, and after graduation from Dhaka Medical College in 1958, he worked for a brief period and then went to Jinnah Postgraduate Medical Center at Karachi and obtained his MPhil degree in pathology in 1963. Professor Islam came back to Bangladesh in 1973 and joined then IPGMR, became professor in 1977 and served as head of the department till his retirement in 1991. He joined BARDEM as honorary consultant the same year and continued till 2000. Professor Karim Nazrul Islam led a successful professional life, creating a modern trend in histopathology, teaching and service in Bangladesh. At IPGMR, he trained more than 70 pathologists. His students are successfully executing their duties in the country and abroad. Professor Karim Nazrul Islam was also a fellow of Bangladesh College of Physicians and Surgeons, Commonwealth Fellow, and was awarded honorary PhD by Bangladesh Bangabandhu Sheikh Mujib Medical University in recognition for his work in the field of pathology. Professor Islam and his wife are now living in quiet retired life amidst his 4 daughters, 2 sons and 10 grandchildren. We requested Sir to come, but now for his physical situation, hardly he go out, so he couldn't come. Again, I would request the representative of Pathology Society, Professor Mahbub Rahman, to take the crest of Karim Nazrul Islam from our chief guest. Professor Mahbub Rahman. There was a time the name of cytopathology was unknown to the whole country. A person dedicated her life to bring this to the medicine community. She worked as the head of cytopathology in National Institute of Cancer Research Hospital. She was awarded as Woman of the Year 2000 by American Biography Institute, USA. I would request Dr. KJ Maula, who is one of the most beneficial of this cytopathology diagnosis in her life when she was working as a gynecologist, to carry the memento for Professor A.J. Inaugural Rahman, Dr. KJ Maula. And I would like to request Professor A.J. Inaugural Rahman to come to the dais to take the crest. Professor A.J. Inaugural Rahman. May I request Professor Nahar Rahman to say a few words to share her experience. Madam.
First of all, I thank you very much for giving me this award. Uh, I think this will act as an incentive to many to do new things. You know, cytopathology, as he has said, was very much unknown. And when I was a postgraduate student, I used to go to the library, and sometimes I see some magazine where they said that at that time FNSE was not so popular. FNSE was introduced maybe in the early 80s, even in UK and America. The FNSEs were usually practiced by a Scandinavian country in the early 60s and 70s. I was a Commonwealth scholar, and I worked in the University of Manchester, the new medical school, 1977 and 78. And even in that time, FNSE was not practiced in UK. So cytopathology was very much done, that is exfoliative cytology. And as you know, that cancer of the cervix was the #1 killer, not only in our country, but also in UK, America, everywhere. And George Papanicolaou was the person who first said that by studying the vaginal smear, you can say whether the person will get a cancer or is having a cancer. And most people didn't believe him. So he first, I think, he published his finding in 1943. And there was a great controversy, you know, even in America and UK. Most people did not believe him that just studying a smear made from the vagina can say the patient has cancer or not. And he was supported by many gynecologists later on because they started doing pap smear, and they found that in some cases, when the patient has no sign symptom, there were abnormal cells. And then in late 1940s, I think, people realized that, yes, these cells are being shed from the malignant area, and they are collected in the vagina, and if you make a smear, you can make a diagnosis. So in the late 1940s and 50s, pap smear was actually introduced as a routine gynecological test. Whenever a patient comes for gynecological test, she used to have a pap smear. And from 1940 to 1960, exact figure may not be, may not know, but something like that in the late 60s, they found that women who do pap smear, many of them have lesions which the cells are in the vaginal smear, but the patient has no complaint of malignancy. So that is, they are being detected in an early stage like carcinoma in situ. So the gynecologist realized that if you can detect this, you can remove and the patient will be cured of the disease. So that is how the people, there were many groups of people who they hold awareness program for the women. In those days, women were very modest, like our countries, and most gynecologists were men, so they did not go for that in those days, Professor Khalek was I will help you in every way. And so he contacted WHO, who gave me all the materials, spatula and everything. And that is how I was able to complete my thesis, research work, and it was appreciated by all. And since then, I'm doing cytopathology in IPGMR. I was posted in Dhaka Medical College, but Professor Nur Islam didn't let me to do that because he said, you have to work in cytopathology, and if you go to Dhaka Medical College, you will be doing other things, so don't go there. And actually, he created a post for me in IPGMR, and that is how I did. And when I went to cancer hospital, Professor Hai probably knows, it was, there was Bosti and two buildings, one government and one by the Rotary Club. And there was no pathology department. So with the help of Professor Hai and some donation people have given, we started this 50-bed hospital, and I used to do not only pap smear and also FNSC there. So that is how it came into being, and all my students, postgraduate students, most of them have done their thesis and research work in different fields of cytopathology, like bone pathology, oral, eye pathology, all you can do by needle biopsy and diagnose them. So this is in short how people have accepted, and now it is, it is practiced everywhere. So thank you all very much for your patient hearing. And I will also thank Bangladesh Oncology Club, of which I am a permanent, I am member, but sometimes they forget to invite me. Anyway, this, I told Professor Hai, I am I think this giving this award will create some incentive for the young doctors so that they will do something new that is being practiced in the Western country, not in our country, and they will introduce this here. And I think this will also give incentive to for proper care of the patient, not only in diagnosis, but diagnosis is very important. Unless and until you diagnose the case, you cannot treat. So in the treatment field, in everywhere, there are so many new things are coming, and people should try to introduce this in our country. Thank you very much for your patience here.
Thank you, madam. Our apology for giving you feelings that we forgot you, but I think today we could prove that we remembered you.
Thank you.
Pediatrics is an old subject in the country, but pediatric hemato-oncology was something never known to anybody. When I was talking to a very young pediatric oncologist, she was telling that Sir is somebody who never worked for any name and fame, a man who worked silently. And that whole community was so emotional when they first heard that Oncology Club decided this year to recognize Professor M. Abdul Mannan Mia for his pioneering role in the Department of Pediatric Oncology. Professor Abdul Mannan Mia was born in Madaripur in 1947. He completed his MBBS in 1970 from Dhaka Medical College Hospital. Then he completed FCPS Pediatrics in 1979. He was the president of Pediatric Hematology Oncology Society of Bangladesh, and he is the president of Bangladesh Childhood Cancer Society, Bangladesh Childhood Cancer Foundation, and he is the ex-chairman and professor of Pediatric Hematology and Oncology, BSMU, and he was also the ex-pro vice-chancellor of BSMU. He was elected as most outstanding pediatrician of Asia Pacific region of 2006 by Asia Pacific Pediatric Association. Oncology Club this year want to recognize him for his pioneering role in the field of pediatric oncology. We could ensured the presence of the first fellow of pediatric hemato-oncology, Professor Afiqul Islam, who was the immediate past chairman of BSMMU, to be with Professor Mannan when we are honoring him with this pioneering role crest. May I request Professor Abdul Mannan Mia to come to the dais, and I would request Professor Afiq, sir, to be with him, because we want to see that the seed that he has planted, the tree has been there, and now the next generation, the students of Professor Afiq is coming out, so the third generation is coming out. Professor Abdul Mannan Mia and Professor Afiq. May I request Professor Abdul Mannan Mia sir to say very brief few words to share his emotion.
Thank you. You must be hungry. Honorable Chairman, Chief Guest, dignitaries on the dais and in front. I am honored, and they have honored me. That's all. And this is a great achievement, I think. There is a mistake in my career. I did my MPhil in pediatric hematology oncology for the University of Edinburgh in 1984. In fact, I am the first student of Edinburgh University in that subject. Subject was itself created in 1975, and I was the first student. I don't know whether anybody did it after that. So, pediatric hematology and oncology. Well, man proposes and God disposes. I was actually a gastroenterologist, and I got a scholarship, commonwealth scholarship in Oxford University under Professor Peter Tijart to do a PhD in gastroenterology. And Allah decided something else. And when, after liberation, all medical colleges were de-recognized by British Medical Council. When two professors, Professor Robertson and Professor Farquhar, came for a visit to recognize these medical colleges, Professor Farquhar was a pediatric professor of Edinburgh University, and Pediatric Association gave a dinner. And Professor Emar Khan was introducing me. His Dr. Mannan, our assistant professor, is going to Oxford for gastroenterology. He said, a military man like you, a strong man, take a strong enemy to fight. Why don't you take pediatric hematology and oncology? I have got a good consultant there. Come to Edinburgh. I said, my flight is already scheduled to go to Oxford. He said, I will change it. I looked at Professor Emar Khan. He just kept a hand on my head, and he said, Mannan, the leukemia children are dying. Nobody survived more than 1 month. I bless you, you will not starve. Take this challenge. And without even discussing my wife and anybody, I said, okay, sir, change my scholarships. And my scholarship was changed, and I became a pediatric hematologist oncologist. That is due to Allah. Nobody else, because it was never my ambition. And two of my OPAs, one of my class friends, Professor Kaiser, Sichuan University professor and head of the department of pediatric hematology oncology, we met him in Shanghai. He said, Mannan, I have got one ambition. When I was a student, I wished if I could give a lecture on this Gallery 1 and Dhaka Medical Cross dais like Professor Rabbi or Professor Rob, my life would have been enthralled. I said, I will make you an arrangement. He came to Dhaka, gave a lecture, and students asked me, if there is a rebirth, what you want to be? He said, every time I will take birth, I will be a pediatric hematologist oncologist. And I also repeat, if I have given a chance again, I will be a pediatric hematologist and oncologist. And because this is highly rewarding. When I went to Edinburgh, I saw the longest survival of acute lymphoblastic leukemia, 1.5 months. Now, I have got so many patients. I am seeing the next generation of these patients who were leukemic at the young age. So, survival has gone close to 60% in BSMMU in pediatric hematology oncology, when it was only 1.5 months when I left the country. And one thing I must request all this, sir is a ideal. Just knowing the technology, just treating the patient will not solve any problem. Will solve a little bit of it. It is a social commitment which the doctors to do. The sir has done a social commitment by doing the National Heart Foundation, and we will all have to do it. And he didn't mention that. We did a childhood cancer home for the childhood cancer patient. Childhood cancer children at Sidirganj by Childhood Cancer Society. There are 20 cabins. Patient can stay there only by 100 taka, full-fledged cabin with all these facilities. So I request you all that you need a social commitment, because government, as sir said, government cannot solve this problem alone. We need help from international committee. We need help from these people. We need help from media, and we need help from doctors. And the best thing is to do decentralization. Just treating at Dhaka will not help any problem, because if a patient, leukemia patient for 5 years comes to Dhaka and goes there and stays at hotel, you can imagine how many millions of taka he needs to be treated. That's why we tried and we created Department of Pediatric Hematology and Oncology in all 8 old age medical colleges. And that is, I think, that is a great achievement in this field. And we did also this first student, MD, and we created this subject. Even India could not do it today. I once attended a meeting of CM7 conference. Mr. Shatrugna Sinha was a Union Health Minister. I was introduced to him, and the Indian friend said, look, Dr. Mannan has opened a course of MD in Dhaka. And we in India even cannot course a DCS in diploma in pediatric oncology. Please allow us. So Shatrugna says, I am an actor, not a doctor. It is your problem. And that was his answer. So last of all, I want to thank one man. He is not here. He is Major General Moti Rahman, my mentor. He helped me all along. Because creating this post, he helped a lot. I said, Moti bhai, do something when as the advisor of the caretaker government. He said, what do you want? I said, I am trying for last 5 years to create between 8 medical colleges. You help me by bringing the paper to me. And he did in such a way, he was going abroad. He called me at night, 8 o'clock in the ministry, come with the paper. He called the secretary and signed it before going to library. And that is the way he pioneered it. In his absence, I was to thank for the development of pediatric hematology and oncology. Major General Moti Rahman has got a great contribution. I am thankful to him. I tried, but it his effort and his help, without his help, I could not create posts, departments in all these medical colleges. Last of all, I pray to Allah for my 2 great teachers, Fazlul Haq and this F. Karim. And one joke, we used to call him Mittu Dot. You know, all teachers have got 2 names. One is given by his students and one is given by his parents. We used to call him Mittu Dut. কারণ একবার যদি স্যারের সাথে দেখা হয় না মরে আর যেত না, মানে ক্যান্সার wasn't this. বলতাম মৃত্যু দূত স্যার। But cancer is not nowadays like that. And 60% of the, more than 60% of the pediatric cancer is being cured at a BCS. This is all. I want to thank Haibai also for this honoring me, honoring these children and organizing such a conference. This will help us a lot, and this encourages a lot. Again, I invite you all to have a social commitment for this. Otherwise, this problem will not be solved just by treating. Thank you, ladies and gentlemen. Thank you, the organizers. And thank you, sirs, for coming here. Thank you.
Thank you, sir. Apology for missing the part of your illuminating life, and also a small correction. Professor Rafiq was the first MD, not the FCPS. We all know that gynecology is a very lucrative subject to practice. Any gynecologist, first passion is to do practice obstetrics. But in this world, there are some fool people who don't take the opportunity to enjoy their life by being an obstetrician, rather try to become a gynecologist. Not only a gynecologist, rather she wants to become a gyne-oncologist. When this lady wanted to become a gyne-oncologist, this was something very new. She had the option to become an obstetrician, very busy obstetrician, and get a name and fame in the country. But it happened other way around. Dr. Khurshid Jahan Maula, who was born in, who was graduated in 1970 from Rajshahi Medical College and done her post-graduation in 1983. She was the first gyne-oncologist appointed in National Institute of Cancer Research and Hospital. And when I saw her in 1993, since then till today, I never heard that she ever attended even a family call of obstetrics. I think that is a big challenge. That is a big challenge for a gynecologist. Not, to avoid obstetrics, not for professional, but also for social reason. This lady dedicated her whole life. Professor Nahar Rahman was telling the story of two buildings. This lady struggled to do the surgery in an operation theater where sometimes when the light was off, torchlight was her only support. Dr. Khurshid Jahan Maula, we want to recognize her for her contribution as the pioneer gyne-oncologist of this country. Today, she is proud to have Dr. Jannatul Firdaus alongside of her, who is going to be the first fellow of gyne-oncology in our country. May I request Dr. Khurshid Jahan Maula to come to the dais, and I want to request Dr. Jannatul Firdaus Jonaki to accompany her with the memento. And I request the chief guest to give the crest to Dr. Khurshid Jahan Maula, probably the only gynecologist of the country who never practiced obstetrics and opted to become a gyne-oncologist. Dr. Khurshid Jahan Maula, would you please come to the dais? Like the improvement of pediatric hematology patient, the mortality of cervical patient has also gone down, survival has gone up. I'm sure we had to name many people for them, but the leader name should come to Professor Dr.
And my my job was in Kuste General Hospital, I did what they mastectomy for cervical cancer without the preoperative biopsy, because patient did not afford two times biopsy before surgery and after surgery. And I read out multiple time. I read out the operative surgery, and I also compelled my husband, who was a surgeon there, to read out the procedure to assist me. And my husband and me do the surgery. Probably it was successful, but today I think that it is not so good enough. And when the histopathology report came from Professor K.M. Nazrul Islam, that squamous cell carcinoma grade 2. And I was very much happy. But on the 21st day, the patient died suddenly by developing tetanus. From that time, I thought that I have to do something. And when my husband was a surgeon in time, and he went to London University for training in urology. And he also provided me for my training in gynecological oncology. I was inspired. Thank you, my husband. I did my training from Royal London Hospital by the guidance of Professor David Oram, who was a very much promising gynecologist in 1992. Then I came to the country and joined in the National Cancer Institute in 1993. Dr. Kamal has told the situation and opportunity of Cancer Institute. I did not get the time for sitting. My director, Professor M.A. Hoy, was very kind to me, and he told me, yes, you have to sit in my room. I spent by sitting 3 months' time in his room. There is no gloves to take the smear. Professor Hoy told me, please make a phone to Nahar, that is AJE Nahar Rahman. At 2:30 p.m., I told Madam, please, will you give me some gloves to take the smear? She was very much kind. By the cooperation of Professor Nahar Rahman and Professor M.A. Hoy, I became this person today. And I had another training from Sloan Kettering Cancer Institute from UK by Professor. And then I proceeded my work still now. I am very much happy to live up the house practice, and now I am going to serve the person only by serving the gynecological practice. I am very much thankful, very much honored to be here. Thank you all. Thank you, the organizer. Assalamu alaikum.
Thank you, madam. Professor Hoy only didn't allow you to sit in his room that day. He always kept a space in his heart for you. That's why, till today, when Professor Nahar madam was here inside the room, first question she was asking whether Jharna is here. That is the bondage they created at that time. They worked together, and from there, we are here today. This is a great day when we are recognizing a family. Just now in her speech, Dr. K.J. Mawla was telling about her husband, a Didian surgeon who assisted her in a first surgery of cervical cancer. The then young surgeon gradually became a urologist. And then, let me quote his word, Kamal, I wanted to survive, so I decided to become a uro-oncologist because my students are so brilliant, they will challenge me and I cannot take their challenge. So let me narrow my field and become a uro-oncologist. Believe me, this is not enough. One day here I will be challenged. Now I am thinking to focus myself to treat only bladder cancer. And one day I am sure one my brilliant student will even eliminate me and I will be out of the street. This is Professor M.A. Salam. He was born in Pabna in 1951. He has completed his MBBS in 1970 from Rajshahi Medical College. And then he took his FCPS degree in 1980 from BCPS. He joins the Ministry of Health to work in the District General Hospital as General Surgeon in 1981. In 1998, he joined the Department of Urology as Assistant Professor in IPGMR, which is now Bangabandhu Sheikh Mujib Medical University. He joined to the Institute of Urology, London, UK for 2 years WHO Fellowship Program. Dr. M.A. Salam returned to BSMMU in April 1992. Since 2003, he worked as Professor of Uro-Oncology in the same university hospital. It is to mention here that he started the Department Uro-Oncology he started the concept of uro-oncology in Bangladesh. And till now, he is working as a uro-oncologist. He is the founder and president and CEO of Urology and Transplant Foundation of Bangladesh. And there, he is still practicing uro-oncology. He is not practicing alone, he is practicing with many of his students, many of his colleagues. And probably he is one of the few group practitioners in this country. He has published more than 54 papers in the field of urology and kidney transplantation in international reputed journals, and his abstracts, international conference, Asia, Europe, and America. Today, I would request Dr. Jahangir Kabir, another famous urologist who is more like a disciple, more like a junior colleague, more like a friend to Professor M.S. Salam, who shadow him whenever he go, to take the honor to carry the crest for Professor M.S. Salam. And I would like to request the Professor M.S. Salam, the first uro-oncologist of this country, to come to the dais and take the crest, and Dr. Jahangir Kabir, consultant of Leavitt Hospital, to carry the crest and give it to him. Professor M.S. Salam and Dr. Jahangir Kabir, please. And this is a unique moment that we have found that both the family member, the life partner, the husband and wife, took the pioneering role of two disciplines of allied oncology subject. This is really something unique. Now, Professor M.S. Salam, very few words to share the experience.
How much time I can make? 1 minute, 2 minutes?
Maximum 2 minutes, sir.
Maximum 2 minutes. Sir, truly I am honored. I have never imagined that I will be honored in such a way by a legendary club who has proven themselves as a civil club, or this is a club which has got a civic sense to recognize others. Unlike the other professional bodies, nobody recognizes anyone. And this is an exception. I appreciate it. And I appreciate it to the extent that I am now the president of Urological Society of Bangladesh, or Bangladesh Association of Urological Surgeons. I will try my best to introduce this concept of honoring other people's, maybe in the next meeting. Today I have got an executive committee meeting. I am going to extend this communication, and the honor which you have paid to us is a true reflection of love and recognition of the others. Truly, I am very much honored, and I wish the greatest achievement of this club. Saying a few words about our development, uro-oncology is a very challenging subject. We have started to implant our urology since 1988. And we have been created so many urologists now, approximately 210 urologists is working all over the country, in the including the peripheral hospitals. But urology is a vast subject because of it has split it into so many disciplines. One of the very important discipline is a cancer. Cancer of the kidney, cancer of the upper urinary tract, cancer of the bladder, cancer of the prostate. Every one itself is a big disease. And I noticed that every urologist started to hate cancer of the urological organs. But the best information is, if it is detected early and if it is treated early, most of the urological cancer can be cured. If not cured, they can be controlled. And if not controlled, even they can be offered a very good palliation so that their life can be very comfortable. So having understood this, I went to the Sloan Kettering Memorial Hospital, where I have learned the tricks of the uro-oncological procedure to some extent. And on return back, I started to practice. And following that, I concentrated all my work in this field for the last almost 12 years. And I was truly inspired by my wife. She is a legendary name in her subject, and she is always inspiring that do something for your cancer patients. So truly, I am grateful to her. And it was somewhat a bedside consultation. I am thankful for this. I am very happy to be here with you and for the honor. Thank you very much, the organizers.
Thank you, sir. The long list is almost at the end. Now I want to share about a very promising student of Mamesi Medical College who was, when we became a student of medical college, you heard about him, about his brilliant career. Again, he could be a surgeon, he could be a general surgeon, he could choose many other disciplines of the surgery, but he opted to choose the surgical oncology as his discipline. Professor Ahmed Said. He was born in Mymensingh in 1955. He completed his MBBS in 1979 and he completed his FCPS in surgery in 1987. He started his career as medical officer at Rural Health Center and then lecturer of anatomy at Mymensingh Medical College. He served as assistant professor of surgical oncology, National Institute of Cancer Research Hospital for 10 years. And during that period, he has implanted the seed of this surgical oncology. Before then, few of our senior colleagues were practicing sporadically, but institutional recognition of this discipline is the result of his effort. Then he joined as an associate professor and became professor of surgery in Holy Family Red Crescent Hospital, and he served there for the last 13 years. Professor Said left Cancer Institute. Professor Said left government. Oncology Club wish this list could be much, much bigger, but it is not possible to recognize everybody in one program. But inshallah, this endeavor will continue. In coming days, we will try to identify more people, recognize more people, not for them, but for us. Now, may I request the President of Oncology Club and the Congress President, Chairman of today's session, Professor M.A. Hai, whom we have awarded today the Lifetime Achievement Award, to give his speech. My teacher, my mentor, our pride, Professor M.A. Hai.
Bismillahirrahmanirrahim. Honorable Chief Guest, National Professor, Brigadier Retired Abdul Malik, leaders of the oncology, guests from home and abroad, participants, ladies and gentlemen, Assalamu alaikum. I am really grateful to Almighty Allah who made it possible to organize this Bangladesh Cancer Congress 2015 today. Boys today has honored me with lifetime achievement. Possibly they want to mean that I should go for retirement from now. I should not.
Thank you, sir. In 2011, in Kathmandu, we had a program of SAARC Federation of Oncology. In the meeting, our founder president, Professor Karim, was telling that I am going to retire. The person sitting in front, Dr. Purvish, said, "Sir, अभी तक मैसेज नहीं आया, मैंने फ़ोन किया, उधर स्पेस खाली नहीं है, जाने का कोई वक्त नहीं है ये." So we want to say the same thing to Professor Hai. This award is not for retirement. This award is for our recognition. Because you are like our mentor, you are like our father, you are like our teacher. So we want to recognize our mentor, our teacher, our father of this subject. That this is recognition to the discipline, not to a person. And we hope You will live for 100 years. You will be leading us and you will be helping us to go forward. Because the mortality rate of cancer in this region is still very low. It's very high, sorry. The survival is very low. And we need to achieve an optimum standard of survival. To go for that, we have a long way to go. Ladies and gentlemen, as a culture of this type of program, we always end this program with vote of thanks. I would like to request Professor Ahmed Said, Treasurer of Oncology Club, to give the vote of thanks. Professor Ahmed Said.
Assalamu alaikum. First, a few words about the recognition and the presentation given to me from Oncology Club. I cannot express my gratitude. I was a little overwhelmed by the news that I shall be awarded something like this. I never thought of getting anything like this. When I joined Cancer Institute, before that I had been working as a general surgeon and never thought of being working as a surgical oncologist. But I was looking for something new, and working as a general surgeon, I was in search of some new era, new scope of work, some innovative work or something like that. And I was lucky that I was selected to work in the National Cancer Institute, which was a project then, and that was very limited facilities there for doing surgery. But we started working there. And I passed 10 years there, and it is, I think, my colleagues there in all the fields of oncology, the radiation oncology, the pathology, the medical oncology, and the then director, Professor Hai, everybody, we had a team there. Though limited facilities, we worked hard and we tried to establish the thing. There was chance for innovation, a lot of patients, and we had to do many things. Whatever we could do, we did it. So I think to be a surgical oncologist, what I am today, all credit goes to my oncology colleagues, all other colleagues who guided me, who helped me, and we always had been a member of a multidisciplinary team, and so credit goes to them. Now we are at the end of this session with vote of thanks, and we are very happy that we have successfully arranged the Bangladesh Cancer Congress 2015 within a very short time. Special thanks and gratitude to our beloved teacher, today's chief guest, National Professor Brigadier M.A. Malik, whose presence gave us a lot of enthusiasm. We are very grateful that, sir, you are here. Thanks to all the foreign delegates and the speakers, participants, accompanying persons for making some time to visit Bangladesh and for joining the Congress. Their participation and presence graced the occasion and put an international flavor to this National Congress. I'd like to thank all the local speakers, participants who were the key figures to make this Congress a success. Special thanks and acknowledgement for all the session chairpersons, moderators, volunteers, Congress, other media personnel, and other support groups. And we are very grateful to all the sponsors whose contribution made things easy for us to make this Congress a success. We are especially thankful to our platinum sponsor, Techno Drugs Limited, gold sponsor, Beacon Pharmaceuticals Limited, and silver sponsor, Sanofi and Roche Pharmaceuticals Limited, and all other organizations and companies for their kind contribution and active support. Last but not the least, thanks to the authority of Army Golf Club, Dhaka, for their hospitality and support. With these few words, I like to conclude. Thank you.
Thank you very much. We are honored that we have our senior teachers here. I can see in the front line our previous directors, previous head of the department, our teachers, whom now are grand teachers because they are third generation students there. We are honored to have Dr. Zafrullah Chaudhary among us. And definitely all the participants who attended this program made it a successful one. Oncology Club believes organizing this type of program. It was a club. It was not a foundation. It was not a society. Because Professor Karim believed in a club we can chat. In a chat we can talk. In a talk we can share. In a sharing we can enrich ourselves. In a barrier of teacher and student, it is very difficult to learn. But if you can break the barrier, learning becomes easy. That was the philosophy of Professor Karim to creating this oncology club. From that chatting, today it is a huge thing. It is the founder organization of SARC Federation of Oncology. This year, we had 600 plus registered participants for this conference. We have been organizing it, and inshallah, we will be organizing it future. We will expect that all the registered participants will enjoy this two-day program. And in the coming days, this support will continue and more new ideas will come. Oncology Club is looking forward for BCC 16, 17, 18 and goes on. Thank you, ladies and gentlemen, for being with us in the inaugural ceremony. I was Dr. A.F.M. Kamaluddin, the International Affairs Secretary of Oncology Club, who was conducting the session. Thank you very much. May I invite you all to join the tea program. Thank you. May I have your attention, please? One. We are extremely sorry that we missed one very important portion, that we missed to give the crest to our chief guest. Now I request our president, Professor M.A. Hai, to give the crest to our chief guest, Professor M.A. Malik sir. I'm extremely sorry for that.
পেনটা তো আমার ইয়ের কাছে পিওর কাছে এই দুটো পার করে নিতে হবে না পার করে পরে দিন হ্যাঁ আপাতত এটা দিয়ে দিই এটাতে বলে ওরা কাজ করছে আসলে কি তাই করছে হ্যাঁ ফটোশপের এর মধ্যেই যায় ঠিক আছে এটা ওরা খুঁজতেছে এটা আমি এখানে সেট করতেছি
ওটা দেন আমার হাতে আমরা তো এটা খুলে নিয়ে নেব এটা এখানে থাকবে না
এদের বসাই দিই এটা হলো আপনার
Karim.
challenge and also window of opportunity at every interval. When you see a patient, you can ask about tobacco use. And rather than being reactive, meaning that you wait for the patient to tell you that he or she is using tobacco, we need rather to advocate proactive approach, which means that we want all healthcare providers to be asking, at least you start with asking, to identify who are among your patients who are using tobacco. I think even when they have been diagnosed with cancer, it's not too late. Of course, it's not what we desire, but sometimes when we are proactive, we can catch them earlier on before they actually diagnosed with such diseases. And most of healthcare professionals, from the clinical setting to the community settings, are accessible, okay? And most of the healthcare professionals are trusted by the public, and they can consult us for help. And there are successful providers of specialized disease management services. For example, majority of the healthcare providers here are related to oncology. And with the advocacy going on in majority of countries, including in Bangladesh, I'm sure, and we will be hearing that afterwards as well, there's an increased role in the public health and health promotion agenda. And some of us, I'm not sure about the situation in Bangladesh, but in Malaysia, all the smoking cessation medications are non-prescribed items, which means you can get them from pharmacists in the community. As I said earlier, we need to get rid of this thinking or myth that it's already too late for some patients, particularly when they have been diagnosed with cancer. So what? Let them continue smoking or using tobacco. No, that's not true. It's never too late. And some people still have the idea that they would not be likely to die kind of a mentality, because we always talk about risks, don't we? For example, we always say 70 to 80% of lung cancer patients are smokers. So some smokers would say, well, I might be in the 20% for sure, but that's a risk that I think is a huge gamble. It's like saying, would you like to get on an airline that has 70 to 80% crash rate versus another airline that has very low crash rate? Okay? There are also people who think it's too hard to quit, it's almost impossible. Well, for some smokers, they may need multiple attempts, some 7 times, or as I've seen in my practice. Counseling while the patient is still smoking or using tobacco. And the idea among healthcare professionals that, well, it's dangerous in certain populations, for example, patients with CHDs, or in pregnancy, patients with cancer, patients with psychiatric illnesses, they're all not true, okay? But last, ICD-10, tobacco use is actually a disorder, a mental and behavioral disorder. And therefore, with classification as a disease, it should be treated. I need you to change your perception when you look at smokers or tobacco users. They are patients in need of help. What you can do is that you can quickly assess their level of dependence. The 2 most relevant questions, which have been shown to be clear, to be correlated with the biochemical validation. The first question is asking them, when do they use their tobacco product? After they wake up. In smoking, we call the question as TTFC, time to first cigarette. Within 30 minutes, most of these patients or smokers are dependent on nicotine. If they smoke faster than 30 minutes, the more dependent they are on nicotine. Numbers per day can be used, but it's not always accurate. Why? Because smoking has these 2 types of topography of how people smoke. Some are deep inhalers. You know the deep inhalers, when they inhale deeply and then they hold it before they blow? I know history, mother, father, either one, siblings, so on and so forth, environmental, and also previous quitting histories can be assessed fairly quickly in your setting. And why it is also important for healthcare professionals to intervene, or to provide the intervention, it is metabolized by the liver enzymes, in this case cytochrome 2b6. And there are poor metabolizers of this drug, therefore the drug would not be so effective. Similarly, someone who is a fast metabolizer of nicotine through the cytochrome 2a6 would then have low level of nicotine because they are rapidly metabolized. So they may need combination among the products, or they may need combination with a non-nicotinic drug. In tobacco smoke, and I have to repeat, this is a common misconception among healthcare professionals. The significant induction is through a substance called polycyclic aromatic hydrocarbons, or PAH. It's not the nicotine that's the culprit causing the induction. It's the PAH in the smoke. It's anything organic. If you smoke marijuana, yeah, you'll get it. If you smoke any kind of organic compounds, you have this. Okay? And PAH is a significant inducer of the cytochrome 1A2. Therefore, it will affect other substances, not just drugs, but also food. That's why smokers drink more coffee. That's why smokers tend to drink more alcohol. Okay? And sometimes, because there are drugs taken by the smokers, which would also be metabolized by this liver enzyme. They would therefore need more dosage, higher dosage of the drugs. Okay? But do remember the reverse side of the story. What would happen when the smokers quit? The enzyme will not be so much induced, and therefore the level of drugs and the substances may go up and may cause toxicity. The detail of it you can review in any literature. For example, here a good review explaining the mechanisms through the pharmacokinetics and also the pharmacodynamics pathway. For health professionals in the hospital settings, I'm sure even in Bangladesh, it is a smoke-free policy. Am I right?
Yes.
Yes. Even in the psychiatric ward. Yes, good. Congratulations. Most countries, they would still allow psychiatric patients to smoke, maybe in the bathrooms. But anyway, when you advocate for smoke-free hospital, that's already half of the battle won. And similarly in majority of places. Because I think you're going to learn later by the other prominent speakers as well that two of the most effective interventions in tobacco control is increase the price, yeah, of the cigarette product, tobacco product, and the next one is to increase or expand smoke-free areas and enforce it. Okay? So more and more usage of, for example, nicotine replacement therapy products. Do you have nicotine replacement therapy products here? Yes? No? No. So there's no medication for smokers. Okay, which doesn't make sense because you treat diseases caused by tobacco, but you're not treating tobacco disorders. So I think you can be a peer pressure group to tell your administrators in the sense that, hey, look, why do we wait until the patients develop COPD, IHD, CHD, lung cancer, and so on, all sorts of cancers, and then you want to try to get them quit smoking? Let them quit now before they get all these diseases. It's more cost effective. In fact, evidence shows it's the gold standard of cost effectiveness in public health intervention. Okay? There are many papers talking about the effectiveness of smoking cessation intervention, and I'm using this as an example because I'm a clinical pharmacist. In the pharmacy setting, there are already support towards smoking cessation intervention. We, very early on, I think this one in 2007, published even a preliminary study on the effect of counseling without medication. And there has been meta-analysis showing that even clinicians, any type of clinician's advice can motivate smokers to quit. So please don't hesitate to say something because you can just ask to identify and you advise using health or any other approaches that you may want to use or a combination thereof to advise the smokers to quit. And when we're talking about quit, we want absolute abstinence. Not switching to another tobacco product, not smoking every now and then, is not even a single puff. Okay? And one of the ways to do it is to equip the healthcare providers. If I ask you now, were you trained during your undergraduates or postgraduates regarding how to help smokers quit? I'm asking you now. Do I see any hands going up? So it's not in your curriculum, right? Why shouldn't it be? It should be. In fact, it's a must. Because it's the major cause of preventable death and diseases in the world today. But you don't learn how to help them. Does that make sense? It doesn't make sense, isn't it? Okay. Now, you may think, wow, if I get all the smokers quit, then I will be out of business. I don't have any patients to treat. No, not really. You will still have cancers. You still have cardiovascular patients, COPD patients. It's not just because of smoking or tobacco use, but it's a major risk. You need to equip. We have started surveying most of our healthcare professionals, universities, programs, and we are happy to report that majority of them have the component of tobacco control and tobacco cessation. Okay? And these are some of the key messages that you can just tell your patients at any opportune moment. Always smoke outside. Either it's outside the home, because there's going to be issues regarding secondhand smoke. Okay? And the dangers, not just secondhand smoke, people are now talking about third-hand smoke. Smoke that, particles of tobacco smoke that are absorbed and then released from curtains, from carpetings, from upholstery, from furniture, from clothings. Yeah? Secondhand smoke is that when you inhale someone else's smoke. Yeah? So you need to know about the drug interactions, caffeine toxicity, because some people do drink a lot of caffeinated food and drinks, particularly drinks. Ask about other substances that would interact. If you have pharmacists in your facility, make them responsible for this. Pharmacists are by default responsible for drug interactions, whether it's drug food, drug disease, drug lab, anything. They are responsible. Okay?
5 minutes to go.
Okay, thank you. And always incorporate harm reduction strategies. This is what I meant just now regarding using evidence-based approved medications to reduce smoking. Why? Products such as nicotine replacement therapy would deliver a bit of nicotine that would otherwise be taken by through tobacco products. So when you give nicotine through NRTs, then the smokers would automatically reduce either the inhalations or the number of cigarette sticks, for example, or the smokeless tobacco used. Okay? Think about mental health patients. Actually, among the mental health populations, schizophrenic patients usually smoke the most.
Tobacco use was 33%, and among them, continuing tobacco consumption after cancer diagnosis was in more than half the patients, 53.8% of patients. Tobacco and risk of death in cancer, 780 prostate cancer men, published in September 2015. Never smokers versus current smokers, and see the increased risk of death. All-cause mortality hazard ratio of 1.5, prostate cancer death hazard ratio of 2. This is the impact if the patient continues tobacco. So tobacco use continues to prey on us even after the diagnosis of cancer. What is the risk of second primary? This is publication again this year, October 2015. 10 French population-based cancer registries, a cohort of more than 10,000 patients. Risk of new malignancies among survivors was 60% higher than the general population when tobacco use was continued. A second primary, so what if it develops? Does it reduce survival? The answer is of course yes. And this is also published in 2015. 579 patients with head and neck squamous cell carcinoma treated with curative intent. Second primary was seen in 15%, 87 of 579. And in fact, the third primary was seen in 8 out of 97. And 10-year survival was significantly less when there is a second primary. So continuing tobacco use after diagnosis of cancer is compromised cure. Within 6 months or a year before quitting tobacco use means compromising chance of cure. So patients who smoke and undergo surgery have an increased risk of several complications, including problems related to general anesthesia. In addition, patients will have delayed surgical wound healing and increased risk of post-operative infection. And this risk is high for those who are smoking up to 2 weeks before surgery. So if you have a newly diagnosed patient with cancer and you have 2 weeks before surgery is going to happen, if he quits tobacco at that time, you will have less complications. And what is the proof? Proof is again published this year in American Journal of Surgery. 246 patients, anastomotic leaks following colorectal resection. 17% in smokers as opposed to 5% in non-smokers. So please remember, when you have faced with a patient who has cancer and is smoking, make sure that it discontinues smoking as soon as possible. It is also true with other forms of therapy. Radiation therapy and cancer increases the risk of all these conditions, and so also with chemotherapy. In fact, as was mentioned in the previous presentation, there is a lot of interaction because of drug metabolism between chemotherapy and targeted therapy as well as tobacco consumption. And this is causing a reduced area under the curve, reducing dose intensity with drugs, chemotherapy drugs like irinotecan and tyrosine kinase inhibitors like erlotinib. And this was published in March of 2015, that study that involved more than 1,000 EGFR positive patients with advanced non-small cell lung cancer. Tobacco also contributes to chromosomal damage. Chromosomal damage also occurs with chemotherapy and radiotherapy. And if this damage gets perpetrated to the second generation of the cells as they divide, it becomes a stable inheritable mutation that will make a cumulative synergistic onslaught on the health of the patient. So this is one more reason why tobacco should be stopped. Genetic risk is compounded by smoking, and you can see that P53 codon 72 polymorphisms increase the interaction between tobacco consumption and lung cancer risk. So is there a solution for this? Can we help our patients with cancer quit tobacco? And I would recommend that you refer to this page on cancer.net, which has a lot of information on this. So what is the benefit of stopping tobacco even after cancer is diagnosed? Longer survival, better chance of successful treatment, fewer side effects, faster recovery from treatment, decreased risk of second cancer, lower risk of infection, more energy, and better quality of life. So we can concentrate on 3 things to get a perfect picture: increased survival rate, decreased risk of secondary cancer, and improved quality of life. So this is published in July 2015, 313 lung cancer patients, 250, that is 80%, participated in a cessation study, 40.8%, 102 actually quit successfully. And in these people who quit successfully, the overall survival was better by 9 months. And for lung cancer, advanced lung cancer, 9 months is almost doubling of the survival. Increased survival rate depends on the length of time between stopping smoking and starting cancer treatment, and therefore we must encourage our cancer patients to stop tobacco as soon as possible. Even a few days can make a difference. There is also decreased risk of secondary cancers, which I mentioned earlier. And cancer patients will also have increased risk of heart attack, pulmonary disease, kidney disease, and cardiovascular disease if they continue smoking. So, can you identify a higher risk among your cancer patients who are consuming tobacco? And there is something called Frank sign. That is a crease in the earlobe, which is suggestive that such patients will have higher risk of cardiac events. So in your general examination, please remember to do this. Why do patients therefore continue using tobacco even after diagnosis of cancer? One is that they hesitate to tell doctors about tobacco habit because of the worry that doctors may judge them, or doctors may provide less support for their cancer if they know that it is because of tobacco. Some patients also think that quitting smoking after a diagnosis of cancer is pointless because they have already developed cancer. And the most important thing is that smoking relieves the stress which is induced by the diagnosis of cancer. So who are the people who are most likely to continue tobacco use even after the diagnosis of cancer is made? And that is younger patients less than 60 years, those who started the habit before the age of 15 years, those with poor performance status, those with low income, and those who live alone. So this is the high risk population where professional help is definitely needed. And it is not an insurmountable barrier. So factors important to know for cessation strategy, again this has already been mentioned to you, so I will skip that. The fact is that among people with cancer, quit rates often exceed 50%. So you can therefore see that at least 1 out of 2 of your patients can quit tobacco with the help of medicine and counseling. So success in setting up a quit strategy is setting a quit date, developing strategies to deal with smoking triggers, and building a network of support. So external risk that prevents cessation particularly is if somebody else in the household is also using tobacco. Here it becomes more difficult for patients to leave tobacco, and therefore professional help is mandatory. Why do I say that? It is in this August 2015 paper on 926 patients, 161 current smokers at the time of cancer, 48% quit after diagnosis, 61% within 6 months. And what was the biggest adverse risk factors? There was an inverse dose response relationship with second-hand smoking exposure because somebody else was using tobacco at home. So successful strategies to stop tobacco in such a circumstances is first, a patient must know that tobacco cessation is important even after the diagnosis of cancer is made. Second, the patient should be motivated. He should come and tell you that I want to quit tobacco, please help me. Third is medication, and fourth is counseling. So quitting tobacco is higher in cancer patients. You can see that this is a comparison between those with cancer and with no cancer. 772 smokers, 2-year quit rate 31% versus 19.5%, 4-year quit rate 43% versus 33%. Another publication in January 1995, more than 10 years ago, 144 new patients, 74 patients smoked in the year before diagnosis, 35% continued tobacco use after surgery. And who are the most likely people to continue tobacco use? Those who are sitting in this audience, the higher educated people. So that is another risk factor. So is there a formal systematic strategy to help these patients? And that is the US National Tips from Former Smokers campaign. This was published in August 2015, and it clearly showed that the 2013 TICS campaign was successful in 1,404 patients with cancer for tobacco cessation.
5 minutes to go.
I'll finish. Thank you. So this is a good resource material for use globally. So what is the take-home message? Tobacco is the #1 cause of preventable deaths. Continues to influence outcome after diagnosis of tobacco is made. It is never too late to stop using tobacco. A successful quit results are based on a systematic management approach, and more cancer patients can be saved and cured if tobacco use is stopped. So the choice is yours. If you are using tobacco, you will see the picture on your left-hand side. If you are not using tobacco, you will see the picture on your right-hand side. Where would you like to be? And would you like to be the zebra that is being eaten by the lioness, or would you like to be the zebra that is eating the lioness? And I would like you to chew on this, but not on tobacco. Thank you very much.
Thank you very much. Now may I request Dr. Gauri Pantavidya. She is the Associate Professor of Head and Neck Surgery, Tata Memorial Hospital, Mumbai. Her topics is tobacco and oral cancer. Dr. Gauri.
very good afternoon to everybody and greetings from Tata Memorial Hospital, Mumbai, India. At the outset, I'd like to thank the organizers for inviting me to speak in this very prestigious Professor Karim Memorial Symposium. Now, tobacco and oral cancer are both topics that are very close to our heart, both in India and Bangladesh. And in the coming few minutes, I'm going to be telling you all about the relationship between these two. Now, oral cancer, as we all know, is a disease predominantly of the South Asian subcontinent. Unfortunately, it presents in locally advanced stages in nearly 60 to 70% of the cases. Treatment of oral cancers is extremely morbid, multimodality, with a poor quality of life. And in spite of all this treatment, the survivals for oral cancer are very poor. In India, oral cancer is the third commonest cancer. It's the second most common cancer in Indian men and the fourth most common cancer in Indian women. The scenario, there is around 30% of the cancer load in the country, and it's truly therefore called what we say the Indian cancer. The scenario in Bangladesh is more or less the same, with oral cancer being the second most common cancer in men and the third most common cancer in women. Now, over the past few years, there seem to have been some changing trends in oral cancer. We are finding a very disturbing trend of higher incidence of oral cancer in young adults between 30 to 40 years. There is an increase in incidence in oral cancer in females, and oral cancer is no longer a disease of elderly males. Students between the years of 13 to 15 years use tobacco. Of this, 85% chew tobacco, while the rest smoke tobacco. Even in the United States, 24.6% of high school students use tobacco. Now, if you look at how tobacco is used, there are two basic forms, smoked or chewed or smokeless tobacco. Now, smoked tobaccos generally constitute the commonest methods of use of cigarettes, BDs or hookahs. BDs, as we know, are tambourni leaves which have been filled with tobacco. Now, BD smoking is more harmful than cigarette smoking. 48% of tobacco consumption in India is by BDs. BDs contain more phenol, benzopyrene, ammonia, and deliver more carbon monoxide than cigarettes. BD also requires more frequent inhalation as it gets extinguished more easily. The average puffs are 28 times for a BD as compared to only 9 times for a cigarette. And then you have the betel quid, which is betel leaf in which tobacco, slake lime, and areca nut is used. And this is classically kept in the lower gingivobuccal sulcus, and that is why we have higher incidence of gingivobuccal sulcus cancers with the use of betel quid. Now, the question that is often asked is oral cancer more common with the use of smokeless, that is chewed tobacco, than smoking tobacco? And the answer is yes. There have been multiple case-control studies in which they have found that smokeless tobacco has a higher risk of developing oral cancer than smoked tobacco. Chewers have a 5-fold increase in the incidence as compared to smokers, which is only 3-fold. Now, to understand why tobacco causes cancer, you have to understand what is called tobacco carcinogenesis, or the process by which tobacco products cause cancer. It is important for us to study this so that we can apply this knowledge to developing effective molecular targets, assessing the individual susceptibility and cancer risk for tobacco control and cancer prevention, and detecting some innovative techniques for early detection. Now, there are multiple carcinogens, nearly 60 carcinogens in tobacco, but I'm going to only talk about two important groups. One are the nitrosamines, and the two are the polycyclic aromatic hydrocarbons. Now, tobacco smoke contains 61 carcinogens. The strong carcinogens are smaller in amount, whereas the weak carcinogens in larger amount. But every cigarette generally contains 1 to 3 milligram of carcinogens per cigarette. Smokeless tobacco has lesser number of carcinogens, as most carcinogens are generally produced because of combustion when you light the cigarette. The levels of polycyclic aromatic hydrocarbons are less, but the levels of nitrosamines are higher in smokeless tobacco. So is there a difference in the carcinogenesis of smoked versus smokeless tobacco? This is a very simplified diagram of what actually happens when you smoke a cigarette. When you smoke a cigarette, the polyaromatic hydrocarbons and the nitrosamines are released, and these form what are called DNA adducts, which cause mutations and changes in many genes, which lead to cancer. And therefore, smoking can lead to cancers of many parts of the body, lungs, oral, bladder, etc. On the other hand, if you look at smokeless or chewed tobacco, it's a combination of two high. Case control studies prove the relationship between tobacco and cancer. Using chewed or smokeless tobacco has a higher incidence of oral cancer. So then what do we do? How do you battle tobacco and oral cancer? Now there are three pivots on which these hold. One is governmental regulations, two is screening for oral cancer, and third is tobacco cessation techniques. I will not be speaking about tobacco cessation techniques since the first two talks had a lot of it. Now, regulations and bans by the government against tobacco industries is easier said than done. It's extremely difficult to ban the tobacco industry. And to the best of my knowledge, Bhutan is the only country which has been largely implementing a tobacco ban. India has implemented a gutkha ban over the last few years. Most countries resort to things like increased taxes on tobacco products, restricting smoking practices in public places, and warnings on tobacco and cigarette packets, and this has decreased the cigarette consumption in countries like the United States. In India, we have been having a systematic ban from 2005 to 2013, and 24 states have now banned the gutkha. But let us see whether this actually has made any effect on tobacco consumption. This is a study that was done by the WHO along with the Johns Hopkins, examining the impact of gutkha bans in selected states in India. They looked at some states in India and they found that the support of the gutkha ban was very high, 92%. There was a universal agreement that 99% that ban is beneficial to the health. 41 to 88% respondents who quit report that the ban was the cause of the quitting. 49% who continue report reduced consumption since the ban. This is another study that we did from the Tata Hospital looking at the impact of gutkha and pan masala ban in the state of Maharashtra. This was a cross-sectional study. 68 users and 5 tobacco vendors were enrolled. 23.5% gutkha users quit using gutkha. 55.8% reduced gutkha consumption, and the non-availability and increased cost was the most important reason for quitting. So yes, bans and regulations will definitely help us, though there is a flourishing black market still for gutkha, but it is a slow process and we have a long way to go. We come to the second strategy, which is screening in oral cancers. Now, screening basically is defined as a process of identifying normal individuals with a higher risk of developing cancer by using easily available and simple tests with an aim to decrease the mortality because of that particular cancer. Now, oral cancer actually has an excellent model for screening, and the reasons are the oral cavity is easily visualized. You do not need to do any endoscopies, CT scans to find out if a patient has cancer. We have very simple and non-expensive screening techniques available. We also have precancerous lesions in oral cancer, and you can identify this at an earlier stage. There is a long latent period to convert from precancer to cancer, and you can implement training or treatment activities during this time. Now, this was a large randomized controlled trial from the Kerala group on screening in people who are at high risk. Then this was published in Lancet in 2005. Cluster randomized trial, effect of visual screening, that is the oral cavity is just opened and you just find out, and that also it's done by trained health workers. There were 13 clusters which were divided into two groups. One group was the screening arm, where there were 3 rounds of oral visual examination. The second was the control arm, where no screening was done. Large number of participants, mind you, these are not patients, these are just healthy individuals. Close to 96,000 in the screening arm and 96,000 in the control arm. They found a 21% reduction in mortality in all patients by using screening. However, this was not statistically significant. What they found was that there was a significant reduction in mortality, 34% in the high-risk group, that is the men who chose tobacco and alcohol. Screening in them reduced the mortality by 34%. However, the role of screening in oral cancers is not yet completely proven. It has the potential to prevent large number of deaths in oral cancer. Screening could be recommended for patients who are high-risk tobacco and alcohol users. However, most countries do not have a screening program in place for oral cancer. In fact, we have an ongoing randomized controlled trial by Tata Hospital in high-risk individuals looking at screening versus non-screening. So I'd like to summarize by saying tobacco is the main risk factor for oral cancers. Use of smokeless tobacco has a higher incidence of oral cancers. Understanding tobacco carcinogenesis is vital because tobacco is not going anywhere. We have to try and find ways to battle this tobacco. Screening has a high potential to decrease oral cancer mortality. Bans and regulations will have a slow but will have positive results in the end. We have always been told that these are what we call weapons of mass destruction, and these are what are used in wars. But wars have killed far less people than tobacco has, and these truly are what we should be calling weapons of mass destruction. Thank you very much for your kind attention.
Thank you, Dr. Gaudi. Our fourth speaker was Dr. Sohela Chaudhary from National Heart Foundation. Unfortunately, due to his flight delay from New York, he couldn't come and he couldn't give the speech on tobacco control in Bangladesh, current scenario and future projection. But now, I would like to request Dr. Harit Chaturvedi, who is the director of Max Cancer Center, to make a small presentation on the upcoming ECOS 2016. Dr. Harit Chaturvedi.
Thank you. Thank you very much. Thanks, Professor Kamaluddin and Professor Hai and the Oncology Club for having me here. And actually, I've come here to invite all of you to the 12th International Conference of Asian Clinical Oncology Society. So, sitting here in the last session of oral cancer and tobacco, I've been in practice for 25 years and I learned quite a few things. I thought that I was a champion of tobacco, but the way Dr. Purvish Parekh superimposed the photographs and conveyed a big message, actually I felt it was the first time it hit me in a way which would touch the students and young people, which I had never before experienced and explained to them. So I feel every session, and just not the way Dr. Gauri explained weapons of mass destruction. So these such things and so much of knowledge comes even to people who feel that they know it all or who are in the field. Because when experts stand on the podium, they make a presentation for 10-15 minutes, they actually spend 2 hours behind it to prepare that presentation. And that richness conveys a lot to the audience at all stages of their career. So I'm here bringing greetings from ECOS 2016. And I want to invite you there for this feast in oncology because I believe that all conferences work as catalysts in our professional journey. And I'm sure when you have exchange of ideas, when you sit there in the audience or you raise a question, you either learn something or you give somebody a message. Other people also learn in the process. So we all here, whether from India or Bangladesh, Pakistan, Nepal, we in SARC share a very common genetic pool, I would say. We share a very common problems, clinical problems. We also, as tobacco is a big burden and so many other things, cervical cancer things. So we all have very common problems and have common strategies to solve. In fact, our socioeconomic and cultural issues are also quite similar. I want to give a brief background about ECOS, which was started in 1991 in Japan and is devoted for care of cancer patients for development of scientific knowledge through research in oncology and promoting the recruitment of facilities and oncology services. If I look back in last 20-25 years, what has happened in oncology scene, I think there's been exponential growth compared to anything before that. If you compare the 50 years before that, I think last 25 years have seen huge growth, and that is primarily because of research, the way it has happened, making things cheaper, more effective, less invasive. That leads to better penetration in treatment. Now, the next 20 years will be even more exciting. I can promise you that. And the reason for that is that the exchanges have grown faster and more accurate. So as this is happening, none of the professionals can afford to sit in one corner or be aloof. You have to engage, you have to work together and create teams. So today ECOS happens every 2 years. And the main mission of ECOS is to make a difference to the Asian oncology through translational research and expert techniques. It covers spectrum from prevention to palliation. It commits mainly to clinical aspect largely and motivates both doctors and patients to create a platform where all stakeholders work together in this fight against cancer. Now, if I look at the previous conferences, it is important to know that this has come for the first time in any SAARC country. Twice before it happened in Japan, China, Taiwan, and Korea. And of these 12 events, 8 have happened in these 4 countries. The other countries have been Thailand, Philippines, and India and Indonesia. India is the 12th country. So I invite you here from India, from New Delhi, and say that let us all treat this as our conference. The SAARC Federation of Oncology, the SAARC community has to treat this as their own event because we need to share our information and knowledge and bring together as much as we can exchange ideas to solve this problem. In this conference, we have already committed more than 100 international speakers. I'm sure you will imagine that the kind of scientific feast you will be exposed to, the kind of ideas you'll get. More than 30 international national societies are shared with the conference. The participation is from more than 30 countries. Across Asia, people are coming from all different parts. So the best part is that students, the young faculty, senior faculty, everybody can participate by giving journals, by submitting abstracts, and participate with their scientific knowledge. Whatever data you have, that will bring value to the conference, and that is the best way to engage on these events. Now we have awards for best posters and oral presentations. We have actually kept lots of awards because we want huge participation from especially the young oncologists. So we have more than 30 awards for registrants on every, I think there's on every 10 abstracts submitted, there will be 3 awards from every country. So there's a large number of awards which will come your way if you submit abstracts. The date has been extended to 31st December. It is possible to go online and visit this website, acos2016.com, and that is the best platform to engage. I just came to know in this morning that there's some problem in transferring or registering online by transferring money. So we'll work it out. The easiest way for you will be to send an email to the Secretariat, we'll respond to you, and then we can create a platform. I have Mr. Rajesh Sharma from Nucleus here. Rajesh, may I request you to please stand? He's here, he'll coordinate with you. He will make sure that we will all collect this data. We'll create this platform so that we can treat ACOS 2060 as our event and make it a success. Thank you very much. Thank you.
Thank you, Dr. Harit Chaturvedi. Now may I request the chairpersons to make their comments. First, Dr. Madan Kepia. He is the patron of SFO. He is from Nepal, but he is a graduate from Bangladesh. Dr. Madan Kepia.
Good afternoon. Since Professor Hai is going to comment on the speakers' topics, I'll just speak a little bit about Nepal because Nepal has not been covered. In Nepal, 80% of the populations in hills and mountains, including children, they are smokers. In city areas, 60% are males and 40% are females. The incidence of lung cancer is increasing very fast because the smoking rate, as you said, is very high. About the head and neck in the Tarai region in the plain, which is adjacent to Indian borders, they have been used to all this gutka, pan, and this tobacco chewing, so the head and neck cancers are high, incidence are high. But now because the influence of this going to the mountains and Himalayan side, the incidence of cancer in head and neck also are increasing. Probably in 10 years' time, it will be quite an impressive ones. About the lung cancer, as Purvis also has suggested, is about 90% are related to smoking. And in my study, it has found that left-sided is more common than right-sided. And both upper zones are more common than other zones. And those who have stopped smoking, the recurrence rate in 10 years is more than 40%. So having said that, I quite enjoyed the pictures posted by Purvis. I hope he continues to do that. Usually he does that. He comes with the new proposals, a new way of doing that. And as Harit said, that it should be focused in not only in the conferences, but when we go to the populations and school colleges, then pictures are quite impressive. So having said that, I would like to give a mic to Professor M.A. Hai.
So I now request
I must thank our speakers, today's speakers, Muhammad Haniki Nik Muhammad, and Parvish Parikh, Gauri Pant Vadya, and Harit Chaturvedi. They all have entitled us with smoking and its bad habits. First thing I do with my patients, I ask them, are you a smoker? If they say yes, I think and give me answer, are you going to quit it or not? Because yes, I'll quit. Now, when you are going to quit, give me a date. Well, like tomorrow, no. You come day after tomorrow for treatment. The day you will quit, I'll treat you from the next date. And naturally they quit it in front of me. I say, you have made a commitment in front of me. If you again quit, you are not going to enter into heavens. You will be burning into the hellfire. So that is why we are just trying it. Well, it's a big mess for us. I would have been the happiest person if we could say that the country has become smokerless. However, we had a very good discussions today. Now, I think, thank you all very much. I don't want to continue more. Now we are going to have some questions.
So now I request the speakers to come to the dais to collect their crest. First, I will call Dr. Haniki from Malaysia to come to the dais and take his crest from the chairman, Dr. Haniki Nik Muhammad. Thank you. Now may I request Dr. Gauri. She is from TMH. Dr. Gauri to take her crest. Finally, I would like to call Dr. Purvish Parikh. Intentionally, I called him at the last because his pictures were more discussed in the total session. Dr. Purvish Parikh, for his a bit different type of presentation, which he committed at the beginning when we invited him. Dr. Purvish Parikh. Thank you. Purvish, if you don't mind, can you please volunteer to give a crest to our chairman?
Yes, of course.
Chairman. And I request Dr. Harit Chaturvedi to come to give another crest to our another chairman. Chairman.
Thank you so much for giving us time, and I invite you also for the course.
Sure.
See you here. So आपको भी आना है एक course में.
Chairman. And I think the last guest is for me as a rapporteur. See, here we end this first plenary session. Now there is a lunch break, and from 2:30, the parallel session will start. 3 parallel sessions will be running in Hall 1, Hall 2, and Hall 3. Hall 1 is here, Hall 2 is in the next building, Level 3 and Level 4. So there will be 3 sessions, head and neck, breast, and GI. Audience are requested to go to the respective session of their interest and attend. And whoever cannot attend the session, I think you have already received the message that you can go to the web link and see it even later. Thank you. Now it is a prayer time, 1:30 to 2 and 2 o'clock lunch will be served, and 2:30 the session will start. So, and we are requesting to enjoy the break, and 2:30 sharp the session will start.
I would like to give an announcement about the Hall 2 and 3 location. Hall 2 is on second floor and Hall 2 is on first floor of this golf club, and Hall 3 is on the second floor of this golf club. So I would like to request our honorable guests to find out which hall is required for home, and I would like to have a seat there after the break is over. Thank you. Attention everyone. I would like to draw the attention of our honorable guest. I want to mention about that which session will be held where. First of all, oral session of multidisciplinary approach to breast cancer management will be held in Hall 2. Head and neck oncology will be on Hall 1, that is here. And oncology updates in GI oncology will be held in Hall 3. I would like to draw the attention of our honorable guest. I want to mention that please see your script and identify which hall will be appropriate for yours. Multidisciplinary approach to breast cancer management will be held in Hall 2. Head and neck oncology will be held in Hall 1, and oncology updates in GI oncology will be held in Hall 3. Hall 2 is on first floor of this building, and Hall 3 is in the second floor of this building. Again, I would like to mention that Hall 2 is on first floor of this building, and Hall 3 is on second floor of this building. Attention everyone, within a few minutes, we will start our oral session on multidisciplinary approach to breast cancer management in Hall 2, head and neck oncology in Hall 1, oncology updates in GI oncology in Hall 3. Attention our honorable guests, now we will start our oral session in Hall 1 within a very few minutes. শুরু করব Now in Hall 1, we would like to start our oral session on head and neck oncology. I would like to request our Honorable Chair, Professor Motiur Rahman Mullah. He is a Professor of Oral and Maxillofacial Surgery, Anwar Khan Modern Medical College, and former Chairman, Oral and Maxillofacial Surgery, Department of Oral and Maxillofacial Department, BSMMU. I would like to request Professor Dr. Ahsan Shamim, And I want to request Dr. Mofizur Rahman to conduct this session.
May I request Professor Hassan Shamim, Senior Consultant of Asana Mission Hospital, to chair the session, and Dr. Mofizur Rahman, Associate Professor of Radiation Oncology, National Institute of Cancer Research and Hospital, to act as a rapporteur for the session. এখানে লেখা আছে।
Now I will request Dr. Mofizur Rahman to conduct the session.
Good afternoon, ladies and gentlemen. This session is Head and Neck Oncology, oral session. May I request the first speaker of this session is Professor Dr. Muhammad Saeed, Chairman, Department of Pharmacy, University of Peshawar, Pakistan. May I request Dr. Saeed, Professor Saeed, please come to the dais with his presentation.
alaikum and very good afternoon. I am Dr. Mohammad Saeed, Chairman Department of Pharmacy, University of Peshawar, and greeting from Pakistan. I am thankful to Oncology Club for organizing Bangladesh Cancer Congress and giving me opportunities to present my research work. So my topic of presentation is smokeless tobacco products, Naswar and cancer. So much has been said about the role of tobacco in causing cancer, and previous presenter Dr. Gori has presented almost similar nature of work as I am going to present. She told about gutka, BDs, pan, and so many other things which are used as a substitute for tobacco. And oral cancer is very much prevalent in Pakistan. And especially in males, the ratio is high as compared to females in Pakistan, and especially the northwest frontier province of Pakistan. So various risk factors associated with oral cancer are tobacco, both smoking and non-smoking, alcohol, marijuana, etc. About 54% men and 20% women in Pakistan use tobacco in one form or other form. And usually this Naswar smokeless tobacco product is used for the cessation of smoking. People use it in order to stop smoking, but it is similarly addictive as tobacco. So Naswar is a STP smokeless tobacco product widely used in Pakistan, especially in our province Khyber Pakhtunkhwa. It is chemically, it is a mixture of powdered local tobacco, Nicotiana rustica, ash and slaked lime. This ash and slaked lime contains heavy metals, and heavy metals are reasons for causing many cancer, and especially cancer of mouth and squamous cell cancer. So it is consumed by pressing it in the mouth cavity, usually between the cheek and gums, or sometimes under the tongue floor of the mouth. After about half an hour, it is then spat out. I don't know it is used in Bangladesh in this form or not, but in our region it is in this BDs, gutka are actually betel, especially betel leaves. Tobacco powder is used in the form of this grinded powder. So smoking tobacco is a well-established risk factor containing various carcinogens. So much so that this nitrosamines have been mentioned. Especially nitrosamines are main causes of cancer, and our previous speaker mentioned that more than 61 carcinogens have been identified in tobacco. So there are previously no study that have determined the carcinogenic contents of Naswar in our region. So this was a type of first study in our region that we studied Naswar for the cause of cancer in human beings. In study number 1, 3 studies were conducted. In study number 1, we determined the potential toxicity of Naswar available on the Pakistani market. And this paper was published in Tobacco Control, having impact factor more than 5. In this study, we collected Naswar from different parts of the Pakistan, like Karachi, Banu, Swabi, Mardan, Charsada, Quetta, Yob, and Muhammad Agency. These are important cities where this Naswar is used. And different brands of Naswar were listed. According to WHO group, carcinogens, proved carcinogens for human tobacco-specific nitrosamines are proved carcinogens according to WHO: arsenic, beryllium, cadmium, nickel, and chromium. These are group 1 carcinogens. And especially arsenic, beryllium, cadmium, nickel, and chromium are found in the slag, lime, and the ash, which is used for the preparation of Naswar. So these group 1 cancer carcinogens are present. Other than nicotine, these can also cause oral cancer. Group 2 cancers, according to WHO, are cobalt, lead, nitrate, and nitrite. So these are also present in the ash, as well as lime, which is used as a part of diluent for the preparation of this Naswar. So we studied the concentration of these heavy metals as well as nicotine. I don't know, you can see this table, and it is clear that all the brands of Naswar were containing these heavy metals like chromium, lead, arsenic, nickel, cadmium, beryllium, nitrite, and nitrate, and main constituent is nicotine. So we have established one formula for potential lifetime cancer risk, which is incremental lifetime cancer risk is equal to ADE, lifetime multiplied by CPF, where ADE lifetime is equal to lifetime average daily oral exposure, that is milligram per kg body weight, and CPF is cancer potency factor, that is body weight per day, and usually it is used 3 to 6 times per day. People are using 3 to 6 times per day. So this calculated lifetime cancer risk from cadmium and lead was 1 lakh to 10 lakh times higher than the minimum 10 raised to the power 4 to 10 raised to the power 6, which is the target range for potentially hazardous substances according to the US Environmental Protection Agency. For chromium, same is the situation, and it is 30 to 35 microgram per day, nickel 35 microgram per day, and arsenic 0.01 microgram per day. So potential toxicity of Naswar was determined on the basis of this chromium, arsenic, and nickel. They were at the top, and in this table different brands were having different levels of these heavy metals. So our results showed that all the toxins studied were well above their allowable limits. All the heavy metals which were determined in the Naswar of different brands from different regions of the province, so they were above the allowed limit. Average level of arsenic was 1.25 milligram per gram, which is higher than the allowable limit of 0.01 milligram per gram. So average minimum daily intake of chromium and nickel was 126.97 milligram and 122.01 milligram as compared to allowable limit, that is 30 to 35 milligram and 35 milligram respectively, 4 to 5 times higher exposure. The average bioavailable nicotine content was 15 milligram per day. The pH was highly basic, averaging 8.56, which favors the formation of tobacco-specific amines. So this high pH of the Naswar, which is due to the addition of lime is also favoring the formation of nitrosamines, and nitrosamines have already been established carcinogens. In study number 2, genotoxic effect of Nuswar in its addicts was determined. So we collected the DNA, and you can see the comet of this degree of comet in the subjects as well as in the control. In study number 3, to find out the association of consumption of Nuswar as an independent risk factor for oral squamous cell cancer was done. So retrospective cohort study conducted at Institute of Radiotherapy and Nuclear Medicine, Peshawar. All patients registered at IRNM with oral cavity cancer was primary our subjects. Only histopathological proven oral cavity carcinoma were included. Metastasis to the oral cavity patients without histopathology report. So 200 patients were interviewed who were admitted to the hospital, and information were taken through a carefully designed proforma containing name, age, sex, address, race, occupation, oral hygiene, tobacco exposure and other confounding factors. If the history of the patient reveals only Nuswar addiction, then the detailed history of Nuswar was used, and including pattern of use, frequency of use, average use per time, average use per day, and duration of use. So data processed through Microsoft Excel 007. So 2 types of parameters were found out: demographic variable, age distribution, geographical distribution, gender distribution, as well as cancer site distribution. Statistical variables were for ODRs. In case of demographic age-wise distribution, 51 to 57 years interval age was selected. This validates our first study that a lifetime risk of 30 years are potentially carcinogenic, and in this study almost all patients were exposed more than 40 years to Nuswar in age group 51 to 71 years. Those who are having this age range 51 to 71 years age, they were exposed for 30 years. Similarly, the maximum patients were from Afghanistan, from Peshawar, and from Swabi. This is geographical distribution of the addicts of Nuswar from Afghanistan, Peshawar, and Swabi. And district-wise, geographical district Peshawar 12%, Swabi 10.5%, from Charsada 8.5%, Mardan 7%, Swat 5%, and Banu 5%. And this paper we have already published in Tobacco Control, as I mentioned you, having impact factor 5. Male and female gender distribution was male were 74.5% and females 25.5%. So male are using more Nuswar as compared to females. So this is because that males are more user of Nuswar than female. Similar observations have also been reported in a local study. So you can see the reference. So cancer site distribution, lip cases were 24, alveolus 43, tongue 7, buccal mucosa 17.5, floor of the mouth 4, hard palate 3.5, and retomilitary gone 4. So cancer site distribution, it is because that Nuswar is directly in contact with lips, alveolus, and buccal mucosa. So oral cavity is actually involved in the use of Nuswar. So these areas are affected. So similar observations has also been reported by Tariq et al. So this is the race-wise distribution. Pashtun were using about 90% Rest of the people, Urdu speaker, Chitrali, Hindu Kush areas, their proportion is very low as compared to Pashtun culture. Pashtun people are heavy user of Nuswar. So OR values were 1.57 and 1.55. So conclusion, Nuswar consumption independently has association with oral squamous cell cancer. This is for our findings that Nuswar causes oral squamous cell cancers. Limitations were that patients available were not cooperative. The response of the patient was not as expected because they don't come for re-examination, and recommendations are more or less same as presented by Dr. Niki as well as Dr. Our previous speaker, Dr. Ghazi, I think. So more specified work should be done on Nuswar and its histology. The production, packaging, sale and consumption of Nuswar should be regulated so as to protect the public from the health hazards associated with its consumption. High levels of toxic heavy metals may be due to the use of ashes, and lime in Nuswar is main cause of cancer in Nuswar users. Thus, their level could be minimized by replacing ash with other binding agents, and the pH can be adjusted with other suitable agents instead of lime. Reducing the basicity will also indirectly decrease the formation of nitrosamines, thus further reducing the product's potential for harm. Microbial contamination can be minimized during manufacturing and storage by adopting hygienic practices. These measures will reduce the potential toxicity of Nuswar. Local small-scale manufacturing in shops should be discouraged. There should be proper packaging that should be labeled with proper warning slogans. Sales to teenagers should be banned. Awareness should be raised in the general public. Conferences, seminars, presentations, and talks should be organized by governmental and non-governmental organizations using mass media to make the population aware of its adverse health effects. So these are two pictures which are showing cancers of the this is one. And thank you very much. Jazakallah khair.
Thank you, Professor Muhammad Saeed, for your excellent presentation.
Thank you. Any question?
Sir, excuse me. We'll take question and answer session after completion of our all lecture.
Okay, thank you.
So may I request our learned audience, please put your question, note down your question. After completion of all lectures, we'll discuss all the papers.
Okay, thank you very much.
Our next speaker is Dr. Gauri Pandey. She is the Associate Professor of Head Neck Surgery Department, Tata Memorial Hospital, India. Her topic is elective versus therapeutic neck dissection in node-negative oral cancer. May I request Dr. Gauri Pandey to come up with her presentation.
A very good afternoon to everybody. Today I will be talking on this topic of elective versus therapeutic neck dissection in node-negative oral cancers. Earlier this year, we had a publication in the New England Journal of Medicine from Tata Hospital. It is the first publication in New England Journal of Medicine, and this was a randomized trial on elective versus therapeutic neck dissection in node-negative oral cancer. I have been asked to speak about this paper, but before I go into the paper, I'm just going to give you an overview of what this whole debate is all about. Now, nodal metastasis is the single most important prognostic factor in head and neck squamous cancers. 40% of our patients present with nodal metastasis. Any patient who has a positive node, the survival of this patient's trait decreases by 50%. It therefore becomes very important for us to be able to manage these neck nodes appropriately because of such an important prognostic value of neck nodes. Now, generally, management of neck nodes in oral cancers is divided into either management of the node negative, that is the N0 neck, or management of the node positive, which is the N plus neck. Today, I will be concentrating only on the management of the node negative or the N0 neck. Now, if you look at the issues that surround management of the neck, there are two things. One is, what is the accuracy of the tools that we have in actually saying that this neck is actually node negative or node positive? And once we decide that this patient has a node negative neck, whether we need to treat this neck or nothing needs to be done for patients with node negative oral cancer. Now, we have a huge armamentarium for questioning neck nodes. The first is clinical examination. We have imaging in the form of ultrasound, CT scan, MRI, PET scan, and we have the sentinel node biopsy. Now, clinical examination has been found to be inferior to imaging for detecting neck nodes. The sensitivity is around 60 to 70% with a specificity of 70 to 80%. We even have a meta-analysis that compared CT scan with clinical examination to say whether this is a node positive or a node negative patient, and the accuracy of CT scan was significantly higher than clinical examination. So clinical examination alone is not a good modality to say whether this patient has positive nodes in the neck or no, you need to add something to it. So the thing that is most commonly added is imaging. There are various different imaging modalities. USG with or without an FNAC, CT scan, MRI. I must say here that if you have a clinically node negative neck, a PET scan is not going to help. PET scan, it's very difficult for PET scan to pick up neck nodes with metastases which are smaller than 1.5 to 2 centimeters. We have a meta-analysis of 17 studies which looked at which out of these modalities is the best, and we found that USG guided FNAC was probably the best modality to detect whether the patient is node negative or node positive. Unfortunately, we have two studies now, both prospective studies from Tata Hospital, in which we have found that ultrasound guided FNAC and ultrasound is not actually very accurate. There is a lot of operator dependent problems with ultrasound, and maybe a CT scan is probably a better modality than ultrasound. Now, what happens is, in spite of clinical examination and imaging, there will be patients who still have neck metastasis, which we have not picked up either on clinical examination or neck node or imaging. And these are what we call occult metastasis, and they occur in around 20 to 30% of patients. So maybe we should treat patients even if they are N0. On the other hand, 70% of patients will not have neck node metastasis, and we will have to unnecessarily give them neck dissections with the attendant morbidity of shoulder dysfunction. And it is from this debate that the question comes up, do we treat or do we not treat a N0 neck? Now, there are multiple options available for treatment of an N0 neck. We can perform elective neck irradiation. You can do nothing, just a wait and watch, or you can do what is called an elective neck dissection. Somewhere in between the wait and watch and the elective neck dissection lies the sentinel node biopsy. Now, there are certain scenarios where neck dissection must be done, even if you have a node negative neck. That is when you have larger lesions, T3, T4 tumors, the propensity for neck node metastasis is high, you must do an elective neck dissection even if it's an N0 neck. Or if your neck is in the field of treatment, that is you're raising a cheek flap to access the primary cancer, you will do a neck dissection. These are no debate scenarios. The debate or whether to do or not comes for these early oral cancers which are node negative, in which the primary can be addressed per orally. You don't need to violate the neck. And in these group of patients, you have to think of whether you want to do a neck dissection or no. Now, we have some evidence before our randomized trial was performed, and this was a meta-analysis of 4 randomized trials which looked at whether you should do elective neck dissection or wait and watch. This 4 existing randomized trials, what they found was that elective neck dissection had a better survival than wait and watch when done in early oral cancers with node negatives. But if you see, the patients that were there in these randomized trials were very small. And this meta-analysis was not without shortcomings. There was a lot of heterogeneity, and we had actually written an editorial in Oral Oncology saying that the answer from this meta-analysis is not clear. We conducted a 2-armed randomized control trial, which is now published in the NEGM on this exact same topic of elective versus therapeutic neck dissection. We included patients aged between 18 to 75 years who had oral squamous cancers, T1, T2, lateralized to one side of the tongue, and node negative on clinical and ultrasound examination. We excluded patients of upper alveolar or palatal lesions, those who had previous treatment to the head and neck, patients who had extensive heterogeneous leukoplakia or submucous fibrosis. The original study was Data and Safety Monitoring Subcommittee, however, advised stoppage of the trial as elective neck dissection showed a significant benefit in the patients. Patients with a minimum of 9 months follow-up were included, and we now have we published with a sample size of 496 patients. Now, the study schema of this patient were the eligible T1, T2, N0 patients were randomized to either receiving elective neck dissection or wait and watch and a therapeutic neck dissection if and when the nodal disease relapses. They were also further randomized into for the follow-up schedule, that was follow-up with clinical examination alone or follow-up with clinical examination and ultrasound. The second part of this has not been published as yet, and I will not be speaking on it. I will be speaking on the results of the first randomization. Now, patients in the elective neck dissection arm underwent intraoral excision of the primary tumor followed with a selective neck dissection, while patients in the therapeutic neck dissection arm underwent only an intraoral excision of the primary tumor. On follow-up, if there was a nodal relapse, then a modified neck dissection was done. Patients who had positive nodes received adjuvant radiotherapy or chemoradiotherapy. Those who had a thickness of more than 1 centimeter or positive resection margins received adjuvant radiotherapy on the study. We had two very simple endpoints. The primary endpoint was overall survival. We wanted to see whether elective neck dissection in node-negative early oral cancers gives an overall benefit of survival as compared to the observation arm, and the secondary endpoint was disease-free survival. We had planned an interim analysis at 250 deaths. However, there was this paper that was published, which I showed you, a randomized trial, and we did an unplanned interim analysis just to see whether we are having excessive deaths in the elective neck dissection arm. And at this interim analysis during the study, we found there was no survival difference, but there was a difference, slight difference in the disease-free survival, so we continued the trial. In 2014, our Data and Safety Monitoring Committee recommended a second action, and 9 patients did not comply to treatment. Adjuvant radiotherapy was given a little more in the elective neck dissection arm, 48.6% versus 34% in the therapeutic neck dissection arm. Our primary endpoint of overall survival showed that in the elective neck dissection arm, there was an 80% 3-year survival as compared to a 67.5% survival in the wait and watch arm, which was highly statistically significant. Similarly, in the disease-free survival, the elective neck dissection arm did far better than the wait and watch arm, once again very highly statistically significant. If you look at the patterns of recurrence in both the arms, in the elective surgery arm, we had 81 recurrences as compared to 146 in the therapeutic surgery arm. There were higher rates of local recurrences in the elective neck dissection arm, but most recurrences in the therapeutic neck dissection arm were nodal in nature. We also then looked at whether we could find some factors which predict survival. We found that other than elective neck dissection, there was something, tumors less than 3 millimeters seem to have no benefit by performing an elective neck dissection. However, there were only 71 such patients who had a tumor thickness less than 3 millimeters, and we have no validated technique to assess tumor thickness preoperatively, and there is a lot of subjective variation in pathology. So this inference cannot be taken that if you have tumors less than 3 millimeters, we can avoid performing an elective neck dissection. But that was a trend, and we probably need more studies in that matter. So the trial showed a highly significant benefit of elective neck dissection in T1, T2 node-negative oral cancers. The absolute overall survival benefit was a high 12.5% and a 23.6% overall benefit in disease-free survival. Higher number of patients in the elective neck dissection arm received radiation, but we do not know if this is the cause of improved benefit in the elective neck dissection group. When elective neck dissection was not done, and I think this is a very important reason why so many patients died when they were only observed. When elective neck dissection was not done, the relapses of the nodal disease that came were all in N2, N3 stages. All these patients had more perinodal extension. If we had done their primary surgery, the neck nodes that we would have picked up would have been much smaller. And this is primarily the reason why the patients in the wait and watch, patients who come back with nodal relapse come with very advanced nodal disease. So I'd like to conclude by saying that neck nodes need appropriate staging and management because neck nodes can kill patients. They are the most important prognostic factors. Elective neck dissection is now, in light of the paper that we published, standard of care in T1, T2 node-negative oral cancer. Just at the conclusion, I would like to invite all of you all to our conference, OncoSurge 2015. This is just a week later, so I'm not sure if any of you all would be able to make it. But this is from the 27th of the 29th surgery, where we show nearly 17 to 19 live surgeries in surgical oncology. Thank you very much for your kind attention.
Thank you, Dr. Gauri Pandya, for your brilliant presentation. Our next speaker is Dr. Nasiruddin, Associate Professor of Department of Oral and Facial Surgery, Dhaka Dental College and Hospital. His topic is mortality and morbidity in oral cancer, how it is related with the management system. May I request Dr. Nasiruddin to come with his presentation.
Bangladesh is a land of stories with wonderful mangrove forest and world one of the largest beach. But sometimes the stories are far beyond expectation. We have to deal a lots of patients who are going to die every year. In last 2 years and 8 months, 468 new cases of oral squamous cell carcinoma are diagnosed in Dhaka Dental College and Hospital. 773 cases in less than 7 years. A large number of them present at an advanced stage. Death number is increasing day by day. So the responsibility goes to home, health facility, socio-economic condition, lack of awareness, management system, who will take that responsibility? Honorable Chairperson, respected delegates, I am Dr. Nasiruddin, presenting mortality and morbidity, oral cancer, how it is related with management system. Most patients attend in advanced stage of oral squamous cell carcinoma due to delayed diagnosis. Surgery and chemoradiation can improve survival rate that may be hindered by medical facilities and our socio-economic condition. the good outcome of treatment of malignancy depends upon some factors. The factors for inappropriate or incomplete adjuvant therapy and their delay as well. To come across the causes of irregular or no follow-up, to investigate the recurrence rate and post-operative mortality and morbidity. We retrospectively review the patient of oral squamous cell carcinoma treated at Dhaka Dental College Hospital from 2009 to August 2015, 6 years and 8 months. And out of total number of patients were admitted patients, 773 squamous cell carcinoma patients. Out of them, we did not find to follow up 518 patients. We followed up only 255 patients. And 255 patients are our study population. Here we can see the trend of increasing oral squamous cell carcinoma patient in various years. 2002 to 1 year, 18 squamous cell carcinoma patient out of 174 total admitted patient. Gradually the patient number are increasing and oral squamous cell carcinoma patient are also increased. And last year, this year, within 8 months we have treated 120 patients and admitted patients are 492 in 8 months. Female patients were more than male patients, and TNMA staging was, in the stage 1, we got only 21 patients, 8% about, and stage 4, 65% patients were with stage 4. Here you can see the stage 4 for reason for delay, patient delay, we have investigated, and most of the patients do not know about oral cancer. Due to unawareness, they delayed for treatment, and economic problem also influence the delay. Surgery done after diagnosis was within 1 week we can treat only 9 patients, and 93 patients we have to wait for more than 3 weeks. This is due to a large number of patients we have to deal, and without squamous cell carcinoma patient we have to operate other pathology also. Here you can see within the few facility, within the 100 bed with 8 cabin, 108, we have to operate all patients. And you can see the total admitted patient in 3 years. In 2013, 883 patients, oral squamous cell carcinoma were 117. January 2014, number of patients was increased, and this year 120. So all these patients we have to deal. Without squamous cell carcinoma patient, we have to deal other patients also. And management done. Surgery, we have operated the patient and we referred the patient accordingly to for adjuvant therapy to Dhaka Medical College or cancer hospital or other. If the patient can bear the expenses, sometimes we refer the patient to also private hospitals. But most of the patient, they do not, nothing done. 18% did not take any treatment, and radiotherapy and surgery only 87%, and only surgery and chemotherapy 20%. I don't know which protocol is it. Surgery, after surgery chemotherapy they are taking. And I have one gentle question to our oncologist, whether there is any role of surgery and chemotherapy in oral squamous cell carcinoma. Adjuvant therapy was taken. 77 patient did not take any adjuvant therapy. And within 6 weeks, 43%, within 4 weeks, 68, 43%, and did not follow protocol, 28%. So we can see the patient did not take adjuvant therapy, 30%. This is more, this is one of the cause of our recurrence of the disease. Why there, so adjuvant therapy, incomplete adjuvant therapy was taken by most of the patient. They do not complete the adjuvant therapy also. And we find out the causes of adjuvant therapy not taking. Most of the patient had economic problem. For this reason, they do not take adjuvant therapy, and also lack of awareness, 55%. And for follow-up, irregular follow-up was most patient or with irregular follow-up, 112%, about 43%, and we cannot contact 18% patient. Only regular follow-up was 81%, 31%. And we have seen recurrence. This is the very devastating condition. Within 5 years, we have seen to die 42%, 16%, and only 37%, 14.5% patient had no recurrence. Worldwide, about 50% of the patients of oral squamous cell carcinoma with advanced disease, but we are finding 80.4% patient with advanced stage 3 and stage 4. For this reason, we cannot give curative surgery to all patients. Out of 255 patients, 115 patients did not receive any adjuvant therapy, or they did not follow any protocol. 24% patients did not take any adjuvant therapy due to economic problem, and 2 to 4 months time required to get radiotherapy or appointment to the government hospital. Though there are some facility of at private hospitals, but out of reach of the maximum people. So in a nutshell, what we are seeing, out of 255 patients, we are getting metastasis and local recurrence, 71, 42% died, no sign of recurrence, only 37, 15% patient. And this is the situation of our follow-up. Dr. George Gregg surely said people are dying of oral cancer because of ignorance. We have to think about it. We have to save them. We have to save the people. We have raised our hands in oral head and neck cancer congress. Also raise our hand here to fight against oral cancer. Thank you very much.
Thank you, Dr. Nasiruddin, for your nice presentation. Our next speaker is Dr. S.M. Anwar Sadat, Consultant, Department of Oral and Facial Surgery, Dhaka Dental College and Hospital. His topic is Fighting Against Oral Cancer, Cause of Failure to Way of Success. May I request Dr. S.M. Anwar Sadat, please come to the dais with your presentation.
Honorable chairs, my respected presence, very good afternoon. Sorry, I am Dr. S.M. Anwar Sadat. I am not consultant of Dhaka Dental College. I am just lecturer of Department of Oral and Maxillofacial Surgery, Dhaka Dental College Hospital and part-time consultant of Square Hospitals. Welcome to my presentation on fighting against oral cancer. We are continuously fighting against the cancer, especially I'm talking about the oral squamous cell carcinomas. And the cause of failure to way of success. My presentation will be on the status of oral cancer in the global context as well as in our country, which will be followed by reasons for failure and way of success, and last 2 slides for the practice of audit and research which help in development of oral cancer surgeries and the other treatments. Oral cancer is one of the 10 most common cancers in the world, and in Bangladesh, India, Pakistan, and these regional countries has the same scenario and accounts for about 1/4 of the cancer in the body. And more than 1 lakh new cases occur every year in South and Southeast Asia with poor prospects of the survival. And this distribution of this disease in Southeast Asia and also some part of Africa and America. And approximately 90% of the oral cancers, especially the oral squamous cell carcinoma in this region, is due to the tobacco habits of different forms, and the smoking tobacco as well as the smokeless tobacco in different forms. And in our study, the scenario is same. This is around 90%. And the risk of this cancer is 10 to 20 times greater in case of the tobacco and tobacco-like chewers than the non-tobacco consumption people. And definitely alcohol adds the synergistic effect to the development of oral cancer, and there are so many factors which is related to the development of oral squamous cell carcinoma, like the poor oral hygiene, poor nutrition, and the broken teeth and the broken dentures, though the conclusive talk is not yet. And the importance of those factors as a cause of oral cancer is very much overshadowed by the tobacco and the chewing or smokeless and also the battlefield and other agents. And here you can see the risk of oral cancer is increasing with the practice of different forms from one form to another form and the combinations. And the battlefield, the risk, relative risk is 1 to 4, and it leads to almost 4 to 25, 8 to 15, 3 to 6, as well as 20 times when the battlefield is incorporated with the smoking and also the alcohols. And in our study, in our squamous cell carcinoma patients, the males are mostly habituated with the smoking and the females are mostly habituated with the battlefield chewing, which is the causative agent for development of this disease. And once it was thought that oral cancer is the disease of elderly population, but it is changing, and we are getting this type of the condition in very early stage, early age, that is around 20 years. And we get most of the lesions in the buccal mucosa and the lower gingiva and the alveolus. And definitely from the previous speakers, we could learn that this malignant disease came to us at the end stage of the disease, at the later stage like the stage 4. And in our study, it is more than 50% stage 4 lesions. How do we treat these cases? With the maxillofacial surgeons, with the head neck surgeons, as well as the oncologists are fighting against the oral cancer with dealing with the different types of the surgery, like the primary surgery, surgery of the neck for neck node positive or the neck node negative event, and also the reconstructions in different types from the primary closure to regional flaps, and also the microvascular, which some of our colleagues started in our country. And our oncologists used to give the service to these type of the patients by various modalities, non-surgical modalities like the radiation and the chemotherapy, preoperatively, sometimes concurrent chemoradiation, and also the post-op adjuvant radiotherapy and the chemotherapy. But what is the goal of our treatment, and what could we achieve by this type of the fighting against the oral cancers? We are giving the treatment for palliation, as well as we are giving the treatment for the cure of the patients. Sometimes we become successful and sometimes we don't. But we are doing continuously, we are giving the support to these kind of the patients. And in our study, the survival rate of oral cancer, the 5-year survival, that is cumulative survival, in the Kaplan-Meier survival curve, the survival rate is more than 60%. And it is almost the same as other countries. It is the overall survival, but the scenario is different when we look for the survival in the stage 4, stage 3, stage 2, and in different size of the lesion as well as the different neck node. And in the log-rank test, we can see the survival rate in the surgery and survival rate in non-surgery almost equal, but the scenario might be different when we see the disease-free survival by the surgical treatment and the non-surgical treatment. And in this slide, you can see from the log-rank comparative analysis, the surgery, stage 1, the survival is 100%, which leads to less than 50% when the lesion is in the stage 4. So that the migration of the survival rate from stage 1 to stage 4 in a very normal manners. And for most countries, this 5-year survival rates of oral cancer are around 50%, but in our study, it is more than 50%. That might be due to the geographic variation and the location of the malignancy, which has better prognosis than other parts of the world. And this survival rate decreased by 50% when nodal involvement we see and present, and further increase on pattern of the nodal involvement from the single node to the multiple nodes. And in our study, this is 64%, and survival steadily declines with the disease specific, that is from the stage 1 to stage 4. So our recommendation is detecting the oral cancer in early stages offers the best chance of long-term survival. And primary prevention by tobacco and other products like the chewing habits and other habit control measures is important in the long-term perspective to prevent the development of the oral cancer, as well as to prevent the migration of cancer from the early stage to the late stage of the disease. The next part of my presentation is what is the reason behind it. We are continuously giving the service to this disease, but we are not getting the success. Our service is limited to the treatment only, I can say strongly, rather than attention to the prevention. We cannot decrease the inflow of our patients to the hospital. We cannot decrease the occurrence of the oral squamous cell carcinoma by any preventive measures. And regarding the treatment, we have so many limitations, like the increasing number of the cancer cases due to a lack of the preventive work in our community, and high inflow of patients in our hospital, and definitely the nature of the oral squamous cell carcinoma, that is heterogeneous type of this presentation, and the plus late presentation of the disease in our patients. And also failure to screen the patients for the treatment by the surgeons in any institute where the inflow of the patients is very high. We cannot screen which we will treat or which we will not treat. We always try to give the treatment to all patients, so that some of the patients cannot get the exact treatment what we want to give due to the crowd. And definitely this type in Bangladesh and also some other parts of the world, this is due to the lacking of spars in this field. As we have a lot of patients, but we have limited number of the oral surgeons and the head neck surgeons to deal with such a big patient. And malpractice, sorry to say, among the surgeons and oncologists, and some attitude of the surgeons and other healthcare providers to get the success in immediate surgical outcome, rather thinking about the patient's welfare and the patient's survival. And lastly, the lack of audit and research in this subject. And how can we overcome this situation? We can prevent the occurrence of the oral cancers, and definitely we can prevent the migration of the precancerous lesion to the cancers, as well as early stage cancer to the late stage of the cancer. And this is possible only by giving attention to the prevention of oral cancer. And this prevention by two ways. We all know, by the implementation of the legislations by the government, any authority, and even individual way, and also the health educations. And the government and the authority can implement the legislations in different ways. I'm not going to talk about that, but we the doctors can do so many things about the legislation. At least we can restrict the smoking and tobacco chewing and other habits in the hospitals, in our clinics, in our private practice, in our community, in our apartment, in our region. Everywhere we can establish these legislations. And that I have talked this legislation not only from the government only, and also by the authority and the individuals. and people can be encouraged to support for adequate enforcement of this legislation. What about the health education? And health, in one of the presentations I have seen this morning that there are so many ways to educate the people, not only to stop the tobacco, but also to reduce the consumption of the tobacco. So to encourage the people, especially the children, adolescents, and the parents, not to adopt the tobacco, battle quit and battle nut habits, and to encourage individuals who use these to stop. And if they cannot stop the tobacco, at least they can be encouraged to reduce the amount and to reduce the number of smoking and to reduce the volume of the chewing tobacco by themselves. And also to encourage individuals to rinse after their use, and they can rinse after using the tobacco habits, that is the chewing tobacco or the smoking. And this can reduce the occurrence of the oral cancers. And also to encourage people not to retain the battle quit, which is very important in developing the squamous cell carcinoma in the buccal circus and the gingiva, and to detect any mucosal abnormality by themselves and report to the specialist.
Your time is almost over.
And lastly, educating healthcare providers, like the oral healthcare providers can be trained on oral lesions and aware of oral cancer as public health problem. And ignoring of oral ulcers and dependence on the canalog, mostly our physicians, our surgeons and the dentists depend on the canalog to treat the precancerous lesions only. But there are so many ways to treat these lesions, so we should be aware of that. And this health education can be established by the person-to-person communication in our everyday practice, and also by the person-to-group communication that we are talking about this oral cancer in this community. And the best way is to mass media. And this type of the primary prevention program can reduce the intake of the tobacco and other chewing habits in the study by the Gupta. And conclusion is primary prevention program can significantly reduce the tobacco habits, and definitely it reduces the occurrence of the premarital lesion and the lesions. And the final two slides will give attention to the audit and research in this subject. And audit will tell us with the healthcare providers about what happens to our patients and what happens to our people. Where is our success? Whether we are success, we have the success in reducing the oral cancer cases or success in the treatment. Regarding the treatment, whether we are successful in the primary control or successful in the neck-net control or the success in the reconstruction in the context of palliation, cure, overall survival, and disease-free survival. And this audit will definitely give true confidence to the physicians and the surgeons to have the treatment, to give the treatment to the oral cancer patients. And this audit definitely direct the surgeons and the physicians from both ways, from surgical treatment to the non-surgical treatment. And by audit and evaluation of these oral cancer cases, the surgeon can decide not to do the surgery, and physicians also can decide not to do the non-surgical treatment. And definitely, this attitude will help the individuals for dealing with the individual health to the public health, which is very important to reduce the number of oral cancer. Then we can be successful in fighting against the oral cancer, I think. Thank you so much. Thank you for patience here.
Thank you, Dr. S.M. Anwar Sadat, for your nice presentation. Our next speaker is Dr. Abdullah Al Masood, Assistant Professor, Dhaka Dental College, Department of Facial-Maxillary and Dental Surgery. His topics is oral cancer and microvascular reconstruction, study of 23 cases. May I request Dr. Abdullah Al Masood, please come with your presentation.
Honorable chairs and learned audience, welcome you all in BCC 2015. Today is my presentation about oral cancer and microvascular reconstruction. I am Dr. Abdullah Al Masood, and all these works are carried out by me and my colleagues, Dr. Shamim Hassan, who is a plastic surgeon. We know the treatment of oral cancer is surgery, radiotherapy, chemotherapy, among these all. But when we say about the surgery, the patient seek the best possible reconstruction with most natural looking result. But complete tumor resection is always the first consideration and must never be compromised for reconstruction. And reconstruction in maxillofacial region should strive to restore the maxillofacial form, oral competence, and oral cavity function, and thus allowing the patients to meet the social needs. This study represents the surgical experience of 23 microvascular flap used for oral cancer reconstruction. Study period is January 2014 to June 2015. Age ranges from 45 to 75 years and sex 9 male and 14 female cases. And all cases we are done is squamous cell carcinoma of the oral cavity. Here we do primary reconstruction in case of 17 patients and secondary reconstruction, that is reconstruction of microvascular free flap, use of free flaps in case of other flaps failure in 6 cases. Here we use 11 radial forearm flaps and anterolateral flaps is 12 in number. 20 cases had shown good functional and aesthetic outcome and 2 cases of failure. One is due to venous occlusion and one is due to ischemic necrosis. So now come to my presentation. It's a oral cancer, stage 4B type, and involving the cheek, use excision of maxilla and mandible in a block, and also the neck dissection, and right-sided anterolateral thigh flap taken based on the lateral descending part of the lateral circumflex femoral artery, and this is the reconstruction. It's another case in the right side, cheek is involved, both the mandible and maxilla also, and reconstruction done by the anterolateral thigh flaps, and this is the outcome after surgery. It's another case, commando operation was done, and anterolateral thigh flap was given, here the anastomosis site, and a few weeks later, the result. Sometimes we want to perform skin-saving surgery. That is, we surgeon try to save the skin. But look, here cheek is not so much thick, and we cannot sometimes judge the lesion, depth of the lesion. For this reason, when surgeon wants to save the cheek, then the skin is very thin, and patient underwent for radiotherapy, and this patient come after radiotherapy with this fistula, and it is treated by anterolateral thigh flap. It's another case of pectoralis major failure, which was reconstructed by anterolateral thigh flap based on the descending branch of the lateral circumflex femoral artery. That's the result. And cancer in the angle of the mouth involving the lower lip and part of the upper lip. Here the 3-dimensional clearance done, and also the neck dissection, and reconstructed by the radial forearm flap. Most of the cases of radial forearm flap, we used palmaris longus tendon to make the sling, to make the oral competency. So another case of radial forearm. It's a case where palmaris longus tendon was absent. We know 8% of cases, individual may be absent of palmaris longus, so you cannot use the palmaris longus for to make the sling, to make the oral competence. So maybe a chance of drooling of saliva. So here this patient has no palmaris longus, so we cannot use the palmaris longus here. Maybe the chance of fascia lata, but second site surgery is time consuming. It's another case of radial forearm flaps. It's a squamous cell carcinoma in the cheek as well as lower lip, and the marking for the excision as well as neck dissection. And this is the excised tissue with part of the mandible, cheek, and lower lip. And this is the excised area. After neck dissection, vessel is preserved. Here, maximum cases we do functional neck dissection, but one of the case we do in the contralateral side anastomosis, as because the primary side was radical neck dissection was carried out in the primary side, so vessels should choose in the opposite side. So it's a difficult. The radial forearm is raised, and you see the healing of the forearm by skin graft. And after anastomosis, and the primary side is after healing, and after radiotherapy, and few weeks later, about 2 to 3 months later, this appearance of this patient. So in conclusion, I want to say, when in cancer, we should need the three-dimensional clearance. So so if possible, do the microvascular free flap first and keep the locoregional flap as a lifeboat. Thank you all.
Thank you, Dr. Abdullah Masood, for your excellent presentation. And thanks all the presenters. Now the time is question and answer and discussion. I am requesting to our learned audience, please mention your identity first and ask your question briefly to the specific speaker. And I'm also humbly request to the chairperson of this session, Professor Ahsan Shamim sir and Professor Motur Rahman sir, to conduct this part and take active part of the discussion.
So anyone having questions? All are satisfied with the papers? Hard? No one coming with questions?
So I think there is no question. Please, mic. Please give him mic. Volunteer.
First your name, then the question, and to whom you are questioning. Your question to Dr. Abdullah Al Masood.
In case of free flap failure, you can use the pectoralis major flap. You can use the delta pectoral flap. As because pectoralis major myofascial flap is you can take a good area, as a big area for coverage. And also you can take delta pectoral flap, or you can take forehead flap. There are many flaps. You can, in case of maxilla, you can take temporalis flap. So latissimus dorsi flap you can take. These are the flap. Okay.
Okay. Any other question? Yes.
Assalamu alaikum. I am Dr. Kamaluddin, Associate Professor, Department of Radiotherapy, Sylhet Osmani Medical College. My question is to Dr. Abdullah Masood. So, after grafting, when radiotherapy should be started, and conventionally we have a dose for radical radiation about 6,000 to 7,000 centigrade. After grafting, how much radiation we can apply to the site, to the affected site, and whether it will affect the graft. So I think Dr. Abdullah Al-Masood will answer the questions.
Thank you, sir. Actually, all of our patients having free flaps, they underwent for radiotherapy. They get 6,000 centigrade, 2,000 per day. And
200.
Oh, sorry, 200 per day. But your question is how much? Oh, actually, dose assignment and something else, it depends on the oncologist, I think. Radiation oncologist will decide whether and how much dose we'll give. But maximum of our patient, when we get them back to our chamber or in our hospital, we have seen that they already take 52 to 6,000 centigrade. But we have no complication after this. But we recommended to give the IMRT rather than the CRT. Then you can modify the doses. Okay, gap will be minimum 4 to 6 weeks. But you know, after 6 weeks after operation, if you start the radiotherapy, there is no advantage of this radiotherapy. According to the author, Jatin Shah, he mentioned that if you want to take the chance of radiotherapy, take the beneficial chance of radiotherapy, you should start the radiotherapy within 6 weeks after operation, not further than that.
Well, I have some observation regarding radiation to the patient, especially head and neck cancer after grafting. These patients, when we started radiation, they react very earlier, and in some cases there is a failure of the flap, and we cannot gain the full dose. At least 5,000 centigrade as adjuvant should be applied, not less than 5,000 centigrade. But in some cases, not in most cases, some cases we cannot achieve the target dose. So this is a limitation. I think we should think about overcoming these limitations. So surgeon should be satisfied whether radiation is required or not required. Wide excision of the surgery must be considered. And justification should be whether radiotherapy should be given or not. This is a crucial question, whether radiotherapy is required for this patient or not. So this should be justified.
Dr. Kamal.
Thank you.
Dr. Kamal, it is the decision of the radiation oncologist whether you will give radiation and how much dose you will give. Any other question?
Assalamu alaikum. I am Dr. Haq, Assistant Registrar of Dhaka Dental College and Hospital. I have a question to Dr. Gauri. If I am not wrong, she mentioned that her was on the N0 neck. So my question is, on what basis or what investigation you did before declaring the patient as N0 neck? What type of investigation did you did? And how much cases you got neck positive after in the excisional biopsy? Is it clear?
So your question is, in the study, how many patients we did? So,
what investigation you did to declare the patient N0?
yes, so we had mentioned in the study that all patients underwent an ultrasound. And if the ultrasound showed that this was a suspicious node, this patient was out of the study. We did not include it because these patients had to be T1, T2 oral cancers and node negative on clinical examination and ultrasound. No, we didn't do a CT scan for this study.
Yes.
But as I showed, we have got 2 more studies that we did, and we find that the sensitivity of ultrasound is not as good.
Right.
And we would recommend that actually as of today, you don't actually need an imaging for neck. Because in every patient now, you have to do a neck dissection. Okay? So there is no need to find out if this patient is N0 or N+. Okay? So you examine the patient, he's either N0 or he's N+. Irrespective of it, you will be doing a neck dissection.
So according to you, we shouldn't include CT scan during investigation?
For the neck, if it's an N0 neck, if you have a large neck node and you want to see which structures are involved, you may do a CT scan. But to find out if it's N0 or N+, it's not really required because you have to do the neck dissection. Even in T1, T2 cancers you have to do, in T3, T4 cancers you have to do. So it's not required. You just need to do a neck dissection in all patients. So to find out whether it's N0 or N+, it's not required anymore. If you want to look at operability, then you may require to do a CT scan.
Thank you, sir.
Thank you. We will take only one question.
Thank you very much. I am Lieutenant Colonel Dr. Azad, Head Neck Cancer Surgeon, CMH Dhaka. Gauri ma'am, thank you very much. Nice presentation. I feel proud because I have done certified 1-year training in head neck cancer surgery in Tata Memorial Cancer Hospital under you. Ma'am, sometimes I feel some problem like SPR squamous cell carcinoma. Thickness, I know that there is 3 millimeter thickness is standard, but sometimes I get 4 millimeter, even 5 millimeter. For this 5 millimeter thickness, will I go for radiation?
So his question is not with regard to neck dissection, it's with regard to radiation. So you have done a wide excision of the tongue, you have done a neck dissection, and now the patient has 5 millimeter thickness. Will you give adjuvant radiation? That's your question. If there are no other factors, like you don't have poorly differentiated tension, lymphovascular embolization, your cut margins are negative, then there is no role of adjuvant radiation. The only role of adjuvant radiation with regard to thickness comes for if you have a thickness which is more than 1 centimeter. But this also is not very well proven. The premise of giving it is that if you have a 1 centimeter thick tongue cancer, it's probably invaded the extrinsic muscles and it probably is a T4 cancer, not actually a T1 or a T2 cancer. So for a 5 millimeter with no other indication of radiotherapy, there is no role of adjuvant radiation.
Thank you, ma'am.
Thank you. We have our oral cancer problem in the Southeast Asia regions with the habits of some our few habits, and the facilities of treatment also is almost very near to every country. So we hope that we have enjoyed the total session of this oral cancer. Now Professor Molla will say something.
Thank you all the speakers for the excellent presentation. And if I just discuss one line for each speaker, like Dr. Saeed from Pakistan, he mentioned about the smokeless tobacco that is called as Naswa, which is quite similar to this country, that we also have a lot of buccal mucosal, or retromolar area carcinoma because of this type of similar type of smokeless tobacco. But interestingly, he mentioned that his incidence rate is very high in lip and alveolus. That's a different part, different from our studies. But thank you again, Dr. Said. And to Dr. Gauri, she has presented a very excellent paper. And I have one just simple question to her, that if you have done any radical neck dissection for N0 node, because
no, absolutely not.
Absolutely not.
Absolutely not. It's just unimaginable in this day and age to do a radical neck dissection for a node negative cancer. We will only perform a selective neck dissection. If we feel that there is positive neck nodes, then we would do a modified neck dissection. But for a node negative cancer, definitely no radical neck
so
dissection.
you recommend that even you don't like to have therapeutic neck dissection, right? You
No
do not like to
therapeutic
wait
neck
and
dissection. There is a huge amount, and we've seen these patients over the last 10 years. The ones that were randomized in the therapeutic neck or the wait and watch, where only the primary was excised, they came with huge neck nodes, unresectable disease, and they died miserable deaths. So that's why the trial was stopped in between, because we had so many more deaths in the wait and watch. So as of today, a simple selective neck dissection, it can be done from a small incision in the neck. You address levels 1 to 3 or levels 1 to 4, and the patient has very good survival in this patient, and definitely no radical neck dissection.
Thank you very much. And next speaker, Dr. Nasiruddin from Dhaka Dental College, Associate Professor. He has presented a very pathetic situation of the outcome, the prognosis of the treatment that normally we can expect, we are seeing in government hospitals. It is not, he's a good surgeon, I know, but it's not his fault, but the system problem that Dr. Anwar also said, that we have to have all these, possibly think of sit together and making a good protocol and think about the prevention. It is very important when we have a limited number of surgeons and the oncologists, you see. So really, I would like to see in future, maybe next year or so, that we have a national protocol for head and neck cancer, you see. That should start from Cancer Institute or Dhaka Dental College or some other place where we deal with most of the head and neck cancer. That should be our dream, I think. Otherwise, what Dr. Sadat was telling, that primarily we become happy doing a good surgery with reconstruction, looks good. But ultimately, what is happening after 3 years, 5 years? That's more important. So possibly the time has come really to refine our protocol and find out a better solution for this country. And the Dr. Sadat is also a very good surgeon, I know him. He's working at both dental college and mostly in Square Hospital. But his prognosis possibly is quite good actually. 64% after stage, I think 3, he said, is 64% is quite good, which declines up when it goes to stage 4 to 40% or something like that. Still is good. I think we should be happy enough if this type of result or prognosis comes from a national institute like Dental College or Cancer Institute. And finally, Dr. Abdul Masood, I would congratulate him because of his unique microvascular technique. But one simple question is that when he is telling, most of these cases I have seen is possibly stage 4, B or even more. So in that condition, you have to do radical neck dissection. You have to do, ultimately, we normally, book says that we have to go for palliative therapy, you see. You cannot go for a curative stage. I mean, surgery technique-wise, you have shown very good pictures. But ultimately, what is the benefit? How we're going to coordinate with other radiotherapy or chemotherapy when we know that our peoples are very poor, you see. So, but this is a very good start for this country that we must encourage Dr. Masood that he has started a very good job, and in future we'll have better protocol, better reconstruction. Very important. Reconstruction is very important also. And that's what I like to say. And thank you once again to all the speakers for your valuable time and audience. Thank you very much.
কেটে দিয়েছে লোক কেটে দিয়ে দেখান লাগবে না ডাইরেক্ট দেওয়া
Our next speaker is Dr. Gauri Pandavaidya. I request Professor Dr. Hasan Shamim to hand over the crest to her. Next, Dr. Nasiruddin. I request Professor Moti Rahman Molla sir to hand over the crest. Now I request Dr. Mufizur Rahman sir to present the crest to Professor Moti Rahman Molla sir. And I request Professor Moti Rahman. Hello? 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 I request Professor Moti Rahman Molla sir to present the crest to Professor Dr. Hasan Shamim. I request Professor Dr. Hasan Shamim to present the crest to our rapporteur, Dr. Mofizur Rahman. Thank you very much. Okay.
Next announcement.
I think this is, thank you very much. This is the end of the session. Next session will start on tumor board soon. So please be seated. Thank you.
Now I would like to request our honorable guest, Dr. Arman Reza Chaudhuri, and our honorable chairman of this session, Professor Ehteshamul Haq, to take their seats. Now I will request our panel of experts, Professor Mutiur Rahman Mullah, Professor Ahsan Shamim, Dr. Vedang Murthy, Dr. Gauri Patvadia, and Dr. Selim Raja. Now I will like to request again our panel of experts, Professor Mutiur Rahman Mullah, Professor Ahsan Shamim, Dr. Vedang Murthy, Dr. Gauri Patvadia, and Dr. Selim Raja. I will request our honorable panel of experts to take their seats. Now I would like to request our moderators, Dr. Arman Reza Chaudhuri, to conduct this session.
Thank you. I am Dr. Arman Reza Chaudhuri, and I am welcoming you all to our today's head and neck tumor board. And our chairman of this session, Professor Ehtishamul Haq, and the panel of experts are here. Now I would like to start my first case. 55 years male smoker presented with left-sided level 2 cervical lymphadenopathy, about 2 into 2 centimeter in size. ENT evaluation revealed only palpable neck. At first, I would like to request our panel of experts, Dr. Selim Raja, to say something regarding this.
Thank you, Dr. Arman. Definitely, this is a typical case sometimes in our practice. The male patient, 55 years, only one node. In physical examination, your CT, MRI, PETs, everything is negative. Even biopsy from different portions is negative. Only the node is positive.
No.
So,
sir, biopsy is positive. Squamous cell carcinoma, grade 2. FNAC.
FNAC.
Cytology is positive.
FNAC positive from node. That is metastasis squamous cell carcinoma.
No, squamous cell carcinoma. Squamous cell carcinoma.
So for further investigations, sometimes now there are so many newer development in the investigations. I may prefer if it is unknown as an unknown primary, then we may do the immunohistochemistry panel to find out the further management. I recommend the immunohistochemistry panel.
Okay.
Actually, I would just want to comment on you doing a little less investigations. These biopsies that you have taken from the tongue base, tonsils, pharynx are actually not required anymore. So if you have a small neck node and your endoscopy, your ultrasound, your pan endoscopy and your EUA says that there is no disease really seen. So if there is a small primary somewhere, we are probably going to treat this with radiation or surgery. It will get taken care of. So doing so many biopsies from 5 places is really not very recommended. If you all have the FNAC is not conclusive, and that says just carcinoma or something like that, then what Professor said probably makes sense. You may have to do excision of the node is something that you have to keep for last. So you do an FNAC, if required you can do a repeat FNAC and you can use immunohistochemistry. But once you get squamous carcinoma, then generally there is nothing much else can you do. The only immunohistochemistry that may be of any help is a P16 analysis. Because if your P16 is positive, then there is a high chance that the primary is somewhere in the oropharynx. So that is the only IHC once you get squamous carcinoma that you require. Otherwise, you don't require anything else.
Any comments from Professor Mutiur Rahman Mullah, sir?
Well, she has mentioned, possibly rightfully, the CT-guided FNAC, but sometimes CT may give you some false report, you see. So if it is simply excisable, why not you take it out and go for proper histopathology? This is one comment. And of course, she is also right. I mean, unless you know the primary lesion through PET scan or other examination, possibly you have to wait and see, and finally, if you detect the primary, then only you can plan neck dissection or some treatment for the primary lesion. But if it is only which is involving the lymph node, which is very unlikely, then I think excisional biopsy could be another choice of treatment. Thank you.
No, I would definitely not agree with that. An FNAC, we don't have to do a CT guided FNAC. You can do a FNAC either ultrasound guided. An FNAC is sometimes all that is required because the treatment for this is not going to be an excision biopsy. The treatment is going to be a formal neck dissection. Just removing that lymph node will vitiate the area around it. You may have to then go back and operate. So if you get your FNAC positive with a diagnosis of metastatic squamous carcinoma, then I would still not recommend an excision biopsy. You would have to go and do a formal neck dissection for the patient, not an excision biopsy.
Well, I'm not saying that FNAC is incorrect, you see. Rather, I'm trying to say, unless you know the primary site, primary tumor, and sometime when it is simply excisable, to get better information, can we not try for excision and go for a proper histopathology? Because the FNAC can really sometime by misdiagnosed by inexperienced pathologist. I don't know what about India, if everything 100% correctly mentioned by the FNAC examination, that is the question.
So actually, I request the panel to concentrate on the point that it is almost specific diagnosis squamous cell carcinoma grade 2. So we should discuss and we should concentrate on this point, I think.
So comments from Professor Hassan Shami, sir.
Immunohistochemistry can be tried if you have enough tissue to do that immunohistochemistry. The size is
2 into 2 centimeters, sir.
A part of the node can be for immunohistochemistry.
Comments from Dr. Vedang Murthy.
So I'll not talk about the histopath. I think enough people have talked about it. So just to summarize, I think if the diagnosis of squamous cell carcinoma is not clear, or you are getting inconclusive on multiple FNACs, or it is undifferentiated, or there are some round cells, you may be suspecting a lymphoma, then you would consider excision. Otherwise, FNAC is enough. My question is maybe to the panel and to you also. Now, PET scan is not easily available in Bangladesh, and it is very expensive. So in the absence of a PET scan, what would be the investigations that we would want to do? So would we want to do a bone scan? Would we want to do a CT of the chest, abdomen, pelvis? So that is something to be thought about.
If PET scan is not available in such cases.
Yes, I mean which is often it is not available. Yeah?
And also costly.
So then what should be the investigation? Then do we need a biopsy, multiple biopsies, or then do we need a EUA and pan endoscopy and directed biopsies? That is something to think about.
So very good question, and I think the answer to that is if your PET scan is still not standard for every patient of unknown primary. So even if you have a PET scan, it doesn't mean you need to do it. A plain, a contrast enhanced CT scan of the head and neck is more than enough. If you have a level 2, the chance that your primary will be in the head and neck is very high. You're not going to have, if you have lower neck nodes, where you have neck nodes somewhere at level 4 and 5, then you will try to look at a primary lower down, and then you will decide whether you need a CT scan of the abdomen. But a CT, contrast enhanced CT scan is absolutely an excellent investigation, coupled with pan endoscopy and EUA to decide to try and find the unknown primary. You don't always require a PET CT.
So any other comment from any expert?
I think we can move on to the next bit.
So, if it is metastatic neck node and unknown primary, so what is the recommendation from the tumor board regarding this management of this patient? Metastatic neck node with unknown primary.
So we would first stage this, and The staging would be T0 because we have not found it, N1 and M0. Okay. Once it becomes N1, it becomes stage 3. Based on that stage 3 disease, we would recommend concomitant chemoradiation approach.
Dabango. So this case should be managed by the multidisciplinary team, first of all, including your radiologist, your histopathologist, your surgical oncologist, and medical radiation oncologist. Especially in this case, I am agree with our previous speaker comment, then should be treated by radiotherapy with concomitant chemotherapy, definitely cisplatin chemotherapy, in this case particularly. Thank you.
From Multidisciplinary Mullah, sir.
But ultimately, what is happening with the primary lesion? Should we just keep quiet or should we look for it?
No, treating with radiation doesn't mean you're keeping quiet. You are treating the mucosal sites of the putative primary. And if you treat all the mucosal sites, then there is long-term data, and this is with radiation. If you treat all the mucosal sites, then the long-term data is the primary appears in the mucosal areas over 10 to 15 years in about 9 to 11% of the cases, which is almost equivalent to appearance of a second primary. So the radiation to the mucosal areas takes care of any small or invisible primary that is there. There can be arguments and discussion about whether you need to treat the mucosa or how much to treat, etc. or not, but it takes care of the microscopic disease that is there.
So I think we can move forward because we are short of time here.
Okay. For my next case, case 2, 18 years old male with the history of left-sided earache, nasal bleeding, nasal blockade, and left-sided cervical lymphadenopathy, 3 into 3 centimeter at April 2014. At that time, evaluation done and posterior nanoscopy revealed growth and biopsy revealed nasopharyngeal carcinoma. FNAC from the left cervical lymph node also revealed metastatic nasopharyngeal carcinoma. Then visited by oncologist and 3 cycles of induction chemotherapy with paclitaxel, 5-FU and cisplatin given up to July 2014. Then received concurrent chemoradiation to the facial region, 66 grain, 33 fraction. But earache not completely subsided. But patient didn't follow up regularly. After 10 months, presented with severe pain in the left side of the face, left-sided earache, and also headache. With the above complaints, patient went to the neighboring country for evaluation further. And there, PET CT scan done. There was mild residual thickening in the left side of the nasopharynx, but there was no significant FDG uptake, and comment was post-treatment residual morphologic changes. But intensely hypermetabolic enhancing soft tissue density lesion in the left side of the base of the skull involving the widened left petrosphenoidal tissue and foramen ovale with extension into the middle cranial fossa and erosion of the adjacent bone represent active malignant residual or recurrent disease. No other metabolically active disease was found. Nasal endoscopy was also done. No frank growth seen, but bony swelling in the right half of the posterior superior nasopharyngeal wall with hyperemic mucosa. MRI of the brain, there was involvement in the temporal region or above mentioned area with suggestive of secondaries. So what is the recommendation from tumor board of this patient?
So in this stage of the discussion, I will request the panelists that one should comment about these things, and if everybody agrees, we will not continue because of short of time. Thank you. I request anybody interested to initiate the discussion. You?
So what is your recommendation?
In this particular cases, so the patient is already received the treatment of
1
induction
year,
chemotherapy.
about 11 months back.
Induction chemotherapy, then radiotherapy, chemotherapy, then after 10 months the recurrence only one node, but other sites are negative. In these cases, the location is the critical site. I prefer the treatment of radiotherapy in these cases particularly, after 10 months or 11 months.
That is, you preferring re-irradiation
Re-irradiation.
of that. Okay,
If there's,
any comment
if,
from
if
the
there's
radiation?
growth between the, if there's difference between the 10 months or 11 months.
Dr. Vedang Murthy.
Yeah, so look, this looks obviously like an inoperable recurrence in the base of the skull, including the intracranial extension. So surgery is definitely out of the question here. Yes, radiation can always be given. We can always switch on the machine and do the planning and give the radiation. But I think the cost of, not the cost in terms of financial cost, the cost of the toxicity that we will produce here is immense in 10 months, especially in the skull, base skull area, which has been irradiated with the cobalt therapy or whatever conventional radiotherapy in the past. Now, if we can find out what the original fields were, if we can find out the original treatment plan, and there is quite a possibility that possibly the fields were inadequate, they were not covering the base of skull, then that area becomes virgin to radiation. It has not received. Then I would, yes, consider radiation there. But given the picture that you have shown, I would like to see the scans. It looks like a situation that needs to be palliated more than anything else. I don't think we can treat this patient curatively from here.
So actually, what should be the gap of re-irradiation in case of nasopharyngeal cancer?
If it is palliation, then it can be done. You can do a 20 grain 5 fractions to that area, irrespective of whether when they have received the radiation, because that is not going to produce much toxicity and patient will not be alive to experience late toxicity. So 20 grain 5 fractions, 30 grain 10 fractions to that area, irrespective of 10 months, 6 months can be done. For palliation, I don't think you can treat this curatively. Other option may be palliative chemotherapy, if that is something that has, although the patient has had induction chemotherapy and concomitant chemotherapy, so whether it will respond to chemotherapy is another question.
Gauri ma'am.
Just what I would like to say is that you have to know what is the symptom that this patient is having. So it's important to know whether this patient is symptomatic or asymptomatic.
Yeah, patient is symptomatic with headache and severe pain in the ear and
if
face.
you have, because this is a nasopharyngeal carcinoma, and if it's a better kind of a nasopharyngeal carcinoma, it's one of the better cancers, let's say, to have. So you have to be able to palliate the symptom adequately. So if you have a lot of pain, then probably you may think about giving re-irradiation. But there is a lot of, when you're palliating, the first thing that you have to know is the symptom. If the patient is not terribly symptomatic, you've picked it up on routine, then you may think of giving palliative chemotherapy, looking at what the, I think in this situation, because the patient already has secondaries elsewhere, it's an M1 disease, I think palliative chemotherapy would be the way to go forward rather than re-irradiation.
Any comments from Professor?
Actually, I fully agree with the final comments here made. But if patient had affordability, can we suggest the patient to put him some clinical trial? Like
It's an excellent idea if there are any clinical trials. Nasopharyngeal cancer doesn't have too many clinical trials running. But yes, if you have a clinical trial running, then you definitely can
if
put
patient can afford, patient can go outside abroad for putting him in clinical trial, because we know Abastin is now also using for some clinical trial in nasopharyngeal carcinoma and very successfully.
Yes.
So we can approach in that way if patient can afford, or some trialist can take this patient.
Absolutely. It's an excellent situation for a trial.
Yeah. So just to add to that, we have treated although I said it wouldn't be useful in general, we have started treating these base of skull tumors now in a very controlled setting. We have last year, 1.5 years now with SPRT. Very, very extremely hypofractionated, 7 to 8 gray per fraction in 5 fractions to a very high dose. I mean, obviously it may not be relevant for this case, but these kind of base of skull tumors can be treated with high precision radiotherapy with almost 50% CR rates at 1.5 years. So something to keep in mind. But again, that is a very technologically intense thing and should not be taken just lightly.
So just two questions to Dr. Vedant Murthy. One is, if it is curative intent, so what should be the gap between the radiation to irradiation, and if it is curative intent, then what should be the dose? Is it full dose, or what should be the dose?
There is no way to think it's curative.
Yeah. So if suppose this case was not as extensive as it is, and suppose it was a much a smaller recurrence which was not going, then I think at least a year you have to leave. It really depends on an individual case-to-case basis. You cannot generalize that 2 years is the cutoff, 1 year is the cutoff. It will really depend on what has been received in the past, what is the condition of the normal tissues, what is the prognosis. There are so many things, Arman. I don't think we can pin down that, yes, 2 years is my cutoff, and 2 years and 1 year and 11 months you will not treat. It is not like that. So I don't think we should put a number to that. It really depends on a whole lot of things. Yeah, and your second question? Dose. So if you're treating with curative intent, do not treat with a half-hearted approach of 50 gray or 55 gray. You have to go at least 66 gray at least, along with chemotherapy if possible. So if you're treating...
During the irradiation also?
Yes. There is evidence for chemotherapy in irradiation. There is evidence that higher dose is better, and there is evidence that IMRT is better. I mean, you have to do it with IMRT, if not IGRT, and full dose 66 gray to 70 gray with chemotherapy. Yeah.
Thank you, sir. Now I would like to request our chairman of this session, Professor Dr. Ehteshamul Haq, sir, to say something and conclude this session.
Okay, I think this is a very nice discussion we have done here. The panelists actually given very excellent opinion regarding the management of both the cases. And regarding first case, actually the problem is that the FNAC report is specific. So we have nothing to do many things for these patients rather than the planning of the treatment. And for the second case, actually, I think the panelists will be agreed on the point that if we can put the patient on clinical trial will be the best options, and the other options will be palliative, definitely, with radiation or chemoradiation. And I thank all the panelists for taking the trouble to come here and giving the opinion regarding these two cases, and the organizer for arranging this session. Thank you.
Thank you.
So any question to the panelist or, yeah? Actually, we are short of time. Oh, yeah. The mic is there.
The second scenario you mentioned, after radiation, will you give some sort of TKI? Any role for TKI?
Not as of today.
Thank you very much. I have a question to Gauri ma'am. Ma'am, regarding the first case, why not neck dissection, selective neck dissection?
Yeah, so that's a good question. I didn't bring it up because I do agree with the good thing about doing a selective neck dissection would be that in some patients, if there is no perinodal extension on histopathology, you may avoid giving adjuvant radiation if it's a single node. But in most patients, you would give adjuvant radiation. So you will be dissecting the neck and then giving adjuvant chemoradiation, which becomes too much treatment for an N1 disease. So for an N1 disease, small neck node, you can easily treat this patient with chemoradiation if this relapses, then you can keep surgery as the second option. But if you, of course, like Vedang said, have multiple nodes big, then I would definitely recommend upfront. A small neck node can be treated with chemoradiation, and because otherwise you'll use up all your modalities of treatment.
Thank you, ma'am.
So, any more questions from the audience? So we can conclude the session, Aman. Thank you for your nice case presentation also.
Here's some
So I think we have some crest for the...
Now I will request our Honorable Chairman, Professor Ehtishamul Haq, to give the crest to Professor Motiur Rahman Mullah. Then I will request to provide it to Professor Ahsan Shamim. Then Dr. Vedang Murthy. Then Dr. Gauri Patvadia. Now, I will request our chairman to provide it to Dr. Gauri Patvadia. Then Dr. Selim Reza. Now I will request Professor Motiur Rahman Mullah to provide the crest to our chairman, Professor Ehtishamul Haq. Now I will request Dr. Gauri Patvadia to provide the crest to our moderator, Dr. Arman Reza Chaudhuri. Thank you, Honorable Chairman, and thanks to the panel of experts and the audience to seize and make our session successful. And thanks to all. This is the conclusion of our session, and that's all.